Going to yeah, 4 wins.
Yeah, wow.
Put up there. Not doing that.
Yeah.
What good weather.
And then somebody with the, like the new pack.
I got you. I totally.
Yeah.
Monday off.
That's fine.
Oh.
No, I get it. But I.
Good, how are you?
Yes. The whole page.
I know, I feel like I was like, right here.
My father-in-law.
Right here is confidential, okay?
Well, it's pretty good.
So, sure, you're on. Love to hear it.
Absolutely.
Busy
It's
summer.
nice. I'm gonna like this one.
Are you?
Kelly Schrader's not,
Oh,
but she will text me. She's watching. She'll text me if she has something to say. So I'll do my best Kelly impression.
Look forward to that.
Okay. Well, it's 9 o'clock. We'll go ahead and get started. Are we live streaming? Okay, thank you. Well, good morning, everybody. Good morning, commission members and folks in the audience, as well as anybody watching on YouTube. Welcome to, I think the fourth meeting of this edition, a meeting of this edition of the Behavioral Health Commission. My name is Jay Chaudhry. I'm the chair of the commission, as well as the director of the Indiana Division of Mental Health and Addiction. I'd like to welcome commission members to the lovely Indiana Government Center for today's meeting. So this meeting is going to be a little bit different than our previous ones in that we don't have any speakers other than just us. And then we have a couple of guests from DMHA that are going to help join us and frame the conversation. The goal of this meeting is to leave with an outline of what we want our final report to contain. So there's going to be some voting on items. There's a couple items that are, I'll be honest, kind of controversial. And I sort of taking the position that we're a deliberative body, we should deliberate and let the chips fall where they may. Like folks to be civil when we're talking about those items, but other than that, feel free to kind of passionately advocate for whatever position you have. We got, I think, 67 recommendations from commission members. We've kind of winnowed that down to about 25-ish. And some of them are going to be combined into other items as well. This is wonderful. So thank you to commission members that submitted recommendations. One thing I would say at the outset is, as chair, and I think my legislative colleagues will, I think, attest to this, having conversations about what the contours of next session will look like. Anything with kind of health and money is going to be scrutinized heavily next session, just for reasons we don't have to get into. So that means, as much as possible, while we do need to make bold recommendations and continue to move the ball forward, we also have to be targeted in what we say. And so just like people keep that in mind. There's a lot of wonderful ideas that will probably not make it into the final report, not because they're not good ideas, but because we don't want the kind of top line headline of our commission report to be, commission asks for a bunch of money, right? Not that we're not asking for money and not that we're not asking for investment, but does that make sense? Any kind of questions, or I don't know if Senator Kreider or anybody wants to weigh in on that piece of it?
Sure. I think that captures it pretty well. It's no secret that the last budget, we kind of undershot the Medicaid spend, and so I will personally be focused on trying to achieve some funding stream that is kind of outside of that discussion. And so I think that's a wise move to try to keep us focused.
All right, thank you. And then a little bit of any comments on that, kind of my comments before we jump into the business.
I just had a question, Jay. So the overall comments that the commission made, the 65, will the commission be privy to the overall comments that maybe the commission might not be able to do something with, but Steve, myself, those of us in the halls
Sure.
might be able to do?
Yeah, we can talk about it. I mean,
Okay,
you were 44 of them, Zoe, so.
I was 44.
Yeah, so. So, thank you. Thank you for your engagement.
Okay.
But yeah, we will definitely, whatever. I mean, no, there were no surprises. They were all good and solid recommendations that would advance the ball.
Okay.
So thank you. All right. And I have plenty too. Okay. All right. With that, the minutes from May 13th. So these were sent out to everybody. Are there any comments on the minutes? Your motion to approve.
I move to approve.
Second. All right. All in favor?
Aye.
Anybody opposed? All right. So first up, I'd like to sort of call Lindsay Potts to the podium, to the hot seat. Right. So Lindsay is our Director of System Transformation at DMHA, which is a cool title that I came up with. And really what she's been doing is no less than transforming our system. She's in charge of our crisis response rollout, which includes 988, as well as the team that's implementing CCBHC in our state. And so her and I are going to kind of tag team, me from here, her from up there, but one of the kind of top line recommendations of the previous commission report, as well as I think explicit direction for us from the General Assembly, was to report on progress on crisis response in 988. So Lindsay's going to share kind of a high level of what we've been doing. And then at the end, I'm going to make a suggestion for a recommendation that we can vote on. So, Lindsay, take it away. I believe Rory is controlling the slides. So.
So can continue to go. So I think Jay can take kind of this first slide around the overview and maybe add onto this or highlight some of the areas of the commission.
Yeah, of course. So SCA 1 in the 2023 session, authored by Senator Kreider, of course, did, 4 things, right? So it moved us further in direction of what CCBHC. It sort of continued to prioritize and strengthen the 988 suicide and crisis lifeline, which we'll talk about. It also directed us to increase access to mobile crisis and crisis receiving services. And it also reestablished the Behavioral Health Commission, which is why we're here today. And again, we've talked about our explicit mandate and statute, but one of them and what this is about is to report on the progress of 988 and CCBHC. And that came out of conversations, Senator Kreider, that you and Zoe and all of us had with legislative leadership to sort of say, okay, like, how do we know how we're doing? How do we know if this was a good investment? And then how are we going to know if we should invest again next budget session, which is our job here today. And, Lindsay, it's kind of all I had on that. So.
Awesome. So we'll go ahead and get started on updates then. So we'll start, if you want to progress to the next slide. So what is 988? And so just a level set that the 988 is a national 3-digit number that Indiana has implemented in our state in a specific way to have the crisis response system. So it's the 988 crisis response system, which is inclusive of 3 pillars. So you see those 3 called out there, the someone to contact, which is the 988 number, someone to respond, which are the mobile crisis teams, and somewhere to go, which are the crisis stabilization units. Crisis receiving and stabilization services is another term we've used across the state for specific sites. And so this 3-pillar crisis system is also integrated within CCBHC. So the strategy here from state level is to not only implement this national number that is continuing to gain momentum, and you'll see some of that growth here in a moment, but also to customize this for Indiana specifically and to integrate it into the other transformative work that we're doing. So it's not only just that we have this new crisis system, but we have this crisis system that's also integrated into our entire behavioral health system, which I think is something very unique about Indiana and is something that we've been really proud about talking how we've integrated CCBHC and crisis response as a more cohesive whole. And we're unique in that way, I think, throughout the nation. So can you go to the next slide? So our progress on pillar 1 And so the 988 volume, you can see there, it's a little small, but you can see kind of where we started about a year ago, a little over a year ago in June of 2023. So just for awareness, on the last slide, it said that 988 started in June of 2022. So we are now into our second year. But just even last year, you can see it's been over a 200% increase in calls. However, we have maintained that answer rate above 95%, which is in the top 10% of the nation through our unified platform. So all 4 of our call centers and 1 text to chat vendor are on a unified platform. We also have a system by which they collect data on a singular system. So that way we can evaluate quality and see the trends in who's contacting 988.
So I think it's also worth, just for our purposes, pointing out that we made significant investments of mostly federal money in our call centers. So that I think that the results are self-evident, but it's because of the investments.
Yes, absolutely. And we're seeing that return on investment as well with how the system is beginning to interoperate. So on the right side there, you can see where our next steps are, which is this integration within our first responder system with 911 and also that CCBHC and community stakeholders and other crisis providers. So our goal at the state is not only are we implementing this model for an Indiana specific way, this is a community specific way. So if you're familiar with our 911 systems, that there's over 100 911 call centers throughout the state. They all do things a little bit differently. So we on our end are trying to meet all of those unique community needs with our integration. So a lot of work still to do in this space. We by no means are at the finish line. If anything, we are at the start of implementing the structure we've created. So we also are seeing more and more calls being directly dispatched from 988. So I was up in South Bend yesterday with one of our HILA CCBHC sites, which we'll talk about in a minute. But they were discussing and we were chatting with the mobile crisis team that serves youth. And they had a 988 dispatch for a youth just yesterday. No, sorry, it would have been Monday. So we are talking through that case and how it's going. So we're starting to see not only 988 socialized throughout the state more consistently, we're also seeing that people are utilizing 988 to get access to mobile crisis for the lifespan, which is really exciting. We'll go to the next slide. So here's our progress on pillars 2 and 3. So pillar 2, as a reminder, is that mobile crisis team dispatch, and then also our crisis receiving and stabilization services and our CSU. So you can see the map there around how this growth has been exponential over the last year. And we've been talking with providers around like, hey, yeah, we built that, we're building a crisis system in a year. How'd that go? And everyone has just been so excited about the work. It's been really revolutionary in many communities on having resources. There's some place to go. There's someone to call. There's someone to respond. One of the quotes yesterday we had from Oaklawn in South Bend was that we're not sure what we did before, which is ideally where this lands, right? The transformation of this is in a decade from now, we think about what did we do with behavioral health crisis before? Because we have a system that's that effective and that our communities trust and is actually making a huge impact for those in need. So you see the numbers there. As I already mentioned, you can see the 3 pillars. We've got the 4 call centers, 1 text to chat. We have 20 mobile crisis teams funded. And as Jay mentioned, this is some unique funding and braiding of resources that we've gotten. So we've been really efficient with how we've gotten this funding out directly to providers in a way that not only utilizes different funding sources, but also utilizes it in a way that gives providers the flexibility and ability to build this system quickly, because that's what we needed them to do. We needed them to stand it up. And as you can see, we've got a lot stood up in just a year. So,
and just to comment on the numbers. So we are also working on a crisis dashboard. So by the time the final report's done, we'll be able to very easily pull not only this information, but also how many dispatches and a little bit other data on like kind of disposition of those dispatches.
yes, yeah. Thank
We're not
you, Jay.
quite there yet. There's some sort of data mechanics that we're working through, but we'll be there soon.
Yeah, we've got, our data team does magic. I was shocked at how much progress we made in such a short time on this. The last iteration we just looked at last week, we have all three, pillars on this dashboard. We're able to have full visibility on the 988 calls with greater detail, but as Jay mentioned, we also we have dispatch numbers, time to response, how many are diverted. So there's specific data points that anyone that we're funding has to report to us currently, and that those reports are quarterly. So this dashboard will be updated every quarter with updated data. All right, we can go to the next slide. So now to transition to CCBHC. And so as we mentioned, we'll discuss how this crisis response system is very much integrated into CCBHC. So certified community behavioral health clinics, as Jay opened up with, Senate Enrolled Act 1 catalyzed this work for us. And we've been working towards this full care transformation. The big bullets there, as you can see, is this ensures access. So this is that 24/7 crisis response. Also access to medication assisted treatments brought out there, but also access to general behavioral health care. So this isn't just recognizing the access for crisis, but CCBHCs have to have quick access for any need, even a non-urgent need. It's within 10 days. And so these are metrics that are tracked as a part of this model. There's strict criteria. And so we have a pretty extensive process by which CCBHCs are being designated, certified within our state. And so we have a team that does both a quality review, chart reviews, site visits to make sure that they're meeting this strict criteria. It's staffing related, reporting, coordination of care, involvement with justice system, education system. So this is a very high bar that these providers have to meet. It is more than just a transition, it is a transformation. And then the receiving funding, which is the critical aspect of this, is that we're asking for a lot more, and we know that that will cost more. And so providers have a shift in funding of how much does it cost to provide care versus modifying their care to fit what will get paid. So this is understanding that behavioral health services don't necessarily fit within a fee-for-service box. And a lot of those fee-for-service boxes that we have don't necessarily meet the needs. And so this opens that up and says, we want you to take care of your communities. How much is it going to cost you to do that? And so that's the transition for payment. Move to the next slide. And so who can? It's anyone. So this is, and no one can be turned away from a CCBHC by need, by payer, any of that. So anyone can walk in. And this also includes youth and the lifespan. So really important to highlight that the services that are there on the right are required for the entire lifespan. So that is youth and also older adults. So the CCBHCs have to tailor programming to meet those unique needs. Those 9 core services, we talked about crisis a bit. This also addresses integrated care with both the screening, diagnosis, and risk assessment, but also with our outpatient primary care screening and monitoring. And so for individuals with behavioral health needs, there are huge health disparities within this population. And so CCBHC addresses that by saying, you know, we're going to need to screen and make sure that everyone has primary care access and is getting their whole health taken care of. And then just some other ones to call out there is services to veterans, that there is specific needs to help support the VA, collaborate with the VA, and really create that safety net for any of those who have served, and specific services that are culturally competent for those who have served. And then also person and family centered treatment planning, integration of family and supports is critical in this. So there are certification criteria that require this and require that documentation. So family are seen and a part of treatment planning, and not just, you know, necessarily they call and they're like, sorry, we don't have a release of information, right? Which is sometimes been the family experience.
Lindsay, thank you for this.
Sure.
You kind of touched on the reimbursement aspect. Has that been finalized, or is that still in process?
As far as like what the sites will get paid.
Right.
So it's almost near final. So
Okay.
we have those rates for each of the 8 sites that are in our pilot group. They have to make them final, CMS has to approve them. So we will be submitting them to CMS by October 1st.
Yeah, and just sort of like a word about money. I mean, so I think in the final report, we will include kind of as final as possible and as specific as possible estimates as we can, but we don't, at this moment in time, we don't have those kind of things finalized. So because of, like, you know, this is a pretty iterative process. And so, you know, it's possible that some of the rates could go up or go down. It's possible that CMS might push back. So there's still some balls in the air that we need to make sure we're, you know, we need to leave ourselves an out right now, although the final report will make it clear that this, you know, as of September 1st, 2024, this is our best kind of estimate of what we think the final thing will cost.
Yes, and in those estimates right now, we're right in line with the other 9 demonstration states
Was
that have
just gonna
gone before us.
Perfect.
So we are not an outlier state, which is nice. We're right in the middle, which I've said to Jay, like, we're mid-pack. That's
where you
a
want
good place to be, right?
Thank you.
Yeah, Great question. Yeah, good insight. All right, so this just a further discussion and visualization on the transition from the current behavioral health system to the future CCBHC state. And so this is breaking down some of those barriers that were structurally in place with our current behavioral health system, as we've already mentioned, because of the payment system and a lot of other barriers that were in place. Now that this system not only transitions payment, it also transitions care and requires integration. You're going to see more of this over time, the integrated and coordinated care approach, not only because of the payment, but because it's required, and we'll have transparency of that. So very exciting stuff on that point. But and then, yeah.
So will you explain in that payment? I think it's really beneficial for the report and also for this group to understand the federal match increased benefit and why pulling down more federally will be impactful to the state with CCBHC model, the FMAP component of it with crisis. and-
Jay wants to take that.
Yeah, so we're getting to that. So,
Okay.
yeah, stay tuned and I will make sure to highlight it when we get to that.
Okay, great.
But it cannot be overemphasized, to be
Yes,
clear.
right.
So, yeah.
Yes, which is that second next point there is that fee for service. That is a quantity focus, that there's a certain number an agency has to reach to be able to be viable. To operate. Now, the prospective payment system is what does it cost to provide care, and provides that more comprehensive funding that ensures stability of our behavioral health system over the long term. And then staff turnover due to low pay, and then the PPS payment can create equity within behavioral health care delivery. So behavioral health providers have traditionally been a lower paid positions at every level, both entry level, which requires no professional degree, and then up through the professional degrees of therapists, nurse practitioners and the like. This allows for that equity to be built into that PPS payment. So that way behavioral health care is on par with all other healthcare delivery. Next slide. Okay, so here's our roadmap to the Medicaid demonstration program. So we had marching orders to apply for the Medicaid demonstration program with SAMHSA, which we did and successfully, quite successfully did. So really proud of the team. Here's been the steps that we took that started really started over a year ago, and even back into 2017, the state's been planning for this. So this was accumulation of a lot of work over several years, but these are more of the direct steps more in the past year that we've taken.
Yeah, and so there's just so people, this is where what Zoe was talking about with the enhanced federal match comes in. So normally Medicaid is about 67% federal, 33% state. So our FMAP will be between 80 and 85%, or it's complicated because it's like 7 different programs with different FMAPs that we have to kind of turn into like one number, but it's going to be significantly higher. And so we're kind of working on what that means financially, but we think it'll be somewhere in the order of like $100 to $150 million extra a year of federal money coming into our state for this purpose.
Yes. So, right, like there was a lot of need to get in this demonstration, and the team delivered. And so, and thanks to, as she mentioned, a lot of collaboration with the OMPP partners as well to do this work, because they're the ones, the actuaries, who can kind of help us better understand this. But this was a interdivision FSSA collaborative project to get this off the ground. So just the steps there, I would just to call attention to that we were selected to be a part of the Medicaid demonstration in early June. Very exciting for our team. We also like to highlight that we got outstanding in every category of the demonstration application, which is not normal. So with the scoring, we couldn't be more proud of the application we put in. But the application really just was a reflection of what the state is doing. So yes, it was written well. However, the content came from the actual work that's happening in the state. So to say that this was a collaboration, not only on an FSSA, this was a collaboration across communities. This was a collaboration across providers. There were a lot and everyone sitting in this room to make this possible. And so we are marching towards that go live of January 1st of 2025 and getting our systems ready to go, which is a lot. We currently have 70 items on that list and it continues to grow. So a lot of hard work to still ahead of us, but we're very excited. So I'll kind of hit on this slide and then hand it off to Jay. But the future of CCBHC and crisis response. And so you can see how these two systems are coming together. And so as we've mentioned with funding, right? Like funding has been critical to the infrastructure build within our state. It wouldn't happen without it, as I'm sure everyone is aware. So how do we sustain the system? And the sustainment comes under the CCBHC system. We're able to tap into the enhanced federal match that's been mentioned. We're also able to tap into other more sustainable systems that give us transparency to this system. So we talked about data. The CCBHC system will track the progress. So this is going to be an indefinite ROI. This isn't we're going to put a bunch of money in and hope for the best. No, this is we're putting a bunch of money in and we will see the work that's being done and be able to report on that to everyone who's put the effort in. And so that's where we see as we transition to CCBHC, which we're starting with 8 sites and we transition to a full state coverage model. Those mobile crisis and CRSS services will be woven into that model. So pillar 2 and 3 can be captured within that PPSP. Do you have anything else to take?
Yeah, no, that was great. And before we turn to kind of what we want our recommendation to look like around this, are there any questions for Lindsay? All right, thank you so much. So the challenge we have with some of this is that, progress here is measured in years, right? Not weeks or months. And so Lindsay mentioned ROI, so we've talked about ROI. I mean, so the earliest we can kind of start to report on ROI for these sorts of things are like, 2-3 years into the demonstration, because it takes that long for this is a complete overhaul of our system. It takes that long for it to happen. So I just wanted to mention that, and I'll kind of go into the report. But as far as recommendations for how we want to incorporate this into our report, kind of 3 parts. So the first would be reporting on progress, which Lindsay's done and will continue to do and continue to have more information as it develops. Number 2, recommend that the General Assembly fund the continued expansion and build out of these 2 systems, CCBHC and the 988 crisis response system. And then number 3, which we will get to in a second, the sustainable funding piece of it. So that's funding that's sort of separate from the general fund appropriation. So before we get to the sustainable funding, I want to have a discussion on number 1 and number 2 and turn those into a motion to recommend. So any questions about reporting on progress or a recommendation that we continue to fund the expansion? Now, see, we've talked about, we need to put more specific numbers onto it, and we will in the final report. We just don't necessarily have them at this moment, but we will by the time the final report comes out. So,
and I just say, obviously, that's important, and we need that, and we need to be able to use that. In terms of, and I understand that we measure outcomes in terms of years, and it is complicated and detailed, but we do know, I don't know at the moment, Lindsay might know off the top of her head, I don't know, but we do know how many calls we get to 988. We do know how many people are served through CCBHCs. We do know how many people, I think, are using mobile crisis. We can total that number. And I think for those of us that are advocating for this at the General Assembly, we should all agree on that number and be able to say it as an elevator pitch.
Great.
And so I don't know what it is, but 200,000 Hoosiers are receiving services through crisis services as a result of Sentinel Act 1. You should be proud of that, and now we need to build on that.
Yep, absolutely. And I think we'll be able to do that pretty well. I mean, I think, again, you never want to make promises when it comes to data mechanics, I've learned, because there's always another problem that seems to pop up, but we're almost there. And I think we'll be there well in time for the report to put that exact number in. And then that's actually one of our requirements, is how many people received mobile crisis services. So
And to me, that could be a pull-out box,
The
that
pullout,
could be
yeah.
a lead in a press release or whatever.
yes, absolutely.
In addition to that number that we know that I think we definitely need to elevate in this report is the diversion from police calls in jails. And all of the providers doing this are tracking that. And that is a significant number. And with our local counties, our local communities, we need to be really sharing that number.
Absolutely. No.
As well as diversion from the emergency room. That there's a cost savings in avoiding the 911 calls and the emergency room visits.
Yeah, and just to kind of put a fine point on both these things, I mean, the numbers off the top of my head, and these are a little bit out of date, but we heard from one of our pilot providers was, the percentage of calls that go to the ER or jails or mobile crisis is really, really small. Like it's something, it's like under like 3% or something. And we'll have more fine number but on it. So those will be the headlines, right? That, mobile crisis keeps people out of jails, out of emergency rooms, treats them in the community. And we'll have the exact number on what, how many there will be. And so we'll have all of this. So again, the plan is for us to take this outline. Our team will go kind of flesh it out and send sort of drafty report out to you all for kind of like more perusal with more details. Again, we want to be targeted, but also have all the right information. So any other discussion points on those?
Then is it possible to also project a future cost savings? So not just what we're saving now, but a projection perhaps?
I think you can do some rough math, right? Like it's not going to be perfect. But I think if you're able to show the number of diversions, you can extrapolate that out. Just if you assume it's the same percentage, if we have 40% of the state covered, we can extrapolate that out to 100% of the state covered. Now it's really rough math. It's going to be like back of the envelope, kind of, and it's never that simple, obviously, but I think we can try.
One other number.
Oh, yeah. Once you talk about so this is part of it too. And we can actually mention this explicitly in the report.
Yeah, so we've engaged WISE, which is the FSSA uses. This is the collaborative between translational research with IU, Purdue, Notre Dame, and they.
It's a cool acronym. You should say what it is. Do you know what it is?
Don't.
Okay.
Remember. So that's why-
It's and I didn't come up with it, but I'm skeptical of that. And it's well-being informed by science and evidence, or WISE. So
Fantastic.
it's pretty good.
That is a
I
really
didn't
good
come up
acronym.
with it. I wish I had.
Obviously, like
Acronym.
what that stood for got cleaned out in my memory bank with all of this other information, but
Jay held on though.
I'll never forget it.
So we're really excited about this project. So we had our kickoff kind of initial brainstorming around this, but WISE is capable of and will be doing our data evaluation for CCBHC. And what we've asked for is not only are they going to help us with getting what we have to report and the quality data, as Jay mentioned, getting quality data is no easy task. And so they're going to help us with this and working with providers to get the data correct. What they're also able to do are state specific reports. So for if the commission or any other stakeholders need information, we have built into that we can enter that request with them. And so the reports can transition from more of like, this is where we are with what we think it is, to this is what science says it will be. So not to overpromise there with the timeline of that, but it is an infrastructure that we have that's part of this.
Yeah, so I think the ROI conversation is going to be a two-part conversation. There's the initial sort of early rollout projection estimate of what we're doing and what we're saving. But then I think more importantly, we're really robustly tracking what we're doing and saving, and we'll be able to sort of continuously report on how that's going.
Yes. Yeah.
And, so go ahead.
I was gonna say, there's another acronym, it's ROI.
Yeah.
And I know we all understand that in this room, the human component, but when we take this to the legislator, we have to
Absolutely.
work with that ROI. Thank you.
Another ROI I don't want to lose sight of is workforce. We have seen in other states significant growth in workforce within the mental health arena. And then just this past year within our system, the CMHC system, who have implemented CCBHC, our vacancy rate and our turnover rate both went down. Just with the model, therapists and clinicians love to be a part of this model. It's a treatment-based model. And so that right there, all hands on deck, that's the model a lot of behavioral health therapists like to work with.
Yeah, and we're gonna need those numbers. the final
Yeah, I
reports.
have that.
All right, great.
And are we assuming then, so just for clarification, are we requesting and do we expect a projection from WISE prior to November of this year?
No, it's pretty early on. They're gonna do it more in real time, right? So they're gonna actually take what's actually happening. We're not gonna have a project. I mean, our projections that we make are gonna be, like I said, back of the envelope math done by us,
Okay.
which is not, I mean,
And will we be able to put that as like in the appendix of the report?
Sure.
Okay.
we can put the headline figure in the body of the report. And that's definitely,
I'd be curious how many of these people are parents as well. So like the kids will benefit from better response, maybe have fewer kids come into foster care, or other kinds of outcomes like that as a result of having better responses to those folks.
absolutely. Yeah. And I think that we should also emphasize, and this is something that I think we kind of gloss over, but Lindsay did a good job of mentioning it, but we should this is a full lifespan. Both of these are full lifespan models. So when we think about our mission, and not only full lifespan, but also, I mean, there's an intersection with IDD as well. So it's not just about, because they're supposed to take all comers regardless of diagnosis, regardless of and so that some of the exclusions that maybe had existed before will fall apart. So I think it's fully in line with every single part of what we're asked to do. Good discussion, good questions. Any other questions or discussion? Can I have a motion to sort of include reporting on progress and recommending that the General Assembly fund the continued rollout of 988 CCBHC as our first recommendation? Anyone want to move?
And I'll gladly motion to support that.
Second.
All in favor?
Aye.
Opposed? All right, so to be continued on that one as we work out all, this is great feedback and we're taking notes there. And all of you will be, whether you like it or not, will be asked to take a look at what we come up with and make suggestions for the final report. All right, so let's move on to funding, because this is a really important part of this, obviously. And it's not just, I mean, so Senator Kreider said this perfectly, you always talk about how, you go in there every year and 90% of the state budget is already spoken for. And then everybody's fighting over that 10%. And everybody has really worthy things they want to fund with that 10%, right? So last report, we recommended, and it got further than I think we thought we would, but didn't get quite to the finish line, on a fee on cell phone bills of $1 to fund, which would generate $90 million a year to go towards this work. So in conversation with several people here, we have we've come up with 3 other options on top of that $1 cell phone fee. What I'd like to get to is a point where we sort of lay out all the different options, as opposed to sort of maybe, because it's really just about sustainable funding. I mean, I think, and there's sort of different stakeholders that have different opinions about the different sources. I mean, in the Indiana Chamber, for example, was not a fan of the $1 fee on cell phone bills. And I don't necessarily think they're going to be again. Right. So that's just, we have to have flexibility. Maybe one of these options will be able to make it through the various stakeholders, and we'll go into these in detail. But I still think we should include the cell phone fee as an option. And we have all that information from the previous report. We can just copy and paste. But the 3 additional ones that I wanted to mention were the cigarette tax, and we'll still have slides with all these in detail, the alcohol tax, and the sports wagering tax. Before we jump into this, Danica, I need you to raise your hand. Where's Danica? Danica Foltz from DMHA spent a ton of time and effort putting this together. So thank you for that. Really appreciate it because I did not want to be doing this. And she stepped up and dove into the Indiana code and budget and figured out kind of what this would entail. So let's move on to the cigarette tax. Oh, next slide. So this is the one that's been there for a while now. I don't know how many years, Senator Kreider. Since you've been there. Yeah. Before you've been there. So this has been on the table. It's gotten conversation. It's never really moved necessarily to the finish line. We always hear that this is the year, but maybe this is the year. But anyway, you can see the mechanics of it there. I'm not going to read it, but any questions on that? So the increase would generate additional $130 million in revenue. So $1.05 increase. And it has additional benefits, which I don't know you're going to talk about.
Are you gonna get to this at the end, but do we have a target number?
Well, so here's the thing about that. The problem with the cell phone fee is its utility is limited because it's governed by the FCC, and the FCC says you can only use it for sort of 988 and 988 adjacent services. So that 90 million would only be able to use one way or another. These three options are as flexible as we want them to be, like, because this is all state funding. It's not governed by any kind of federal statute here. So I don't have a target in mind that's deliberate because I think I want to give Senator Kreider sort of maximum flexibility in those rooms when he's arguing for these sorts of things, to say like, this is going to, because I mean, we have to be honest here. This is a constantly kind of moving target, right? Because, with not only inflation, cost of living, there's no way to hack behavioral health. Like it just requires time and people, right? And so, I don't want to make it seem like if we get to that $150 million, like we are good. We don't need anything else ever again. But this can sort of be that baseline in which we can operate and maybe be a buffer sort of in downturn times and whatnot. So it's a great question. I'm open to push back on that, or if you have other thoughts on that, Steve, but that's kind of my thought on, like, do we have a target?
I may have thoughts, but I'll
Yeah.
hold off.
Okay. No, I'd love to hear them.
Just from conversations with, potential future leadership, having a target, like that's the number one question, right? So if we could get that more defined, I think that would be
So
helpful.
we will have a target number for you for CCBHC and crisis response in the final
Okay.
report, like for sure.
Okay.
That's again, I'll guarantee that. The other thing, we'll get to where we're talking about children's stuff, and we'll talk about some suggestions from ARP and some other folks. If we want to include that in the target, or if we want that to be a separate conversation, I think it's still an open question. So, but we'll have a target for these two things for sure.
Okay.
And the question for the group is, do we want to limit the sustainable funding piece to these things? Do we want to say these things have sort of the first bite at the apple and then everything else? Or so those are open questions that we should have a discussion about once I get through these options. So the cigarette tax, number one. Number two, next slide. The alcohol tax. This has not been increased in a long time. Something like 45 years. Yeah. Obviously, it's also backed by some powerful lobbyists and some powerful interests. So we have to, again, I'm just trying to be realistic about these options.
We just, reinstated happy hour,
Yeah.
right? So
So
is
maybe
there an offset?
revenue will go up.
Yeah.
Yeah. No, I think, it's one, alcohol is, is a pretty destructive substance. It's one of those things that's really normalized. But I think it kind of glosses over that kind of devastation sometimes. And so I do think there is a moral argument to be made here. And as well as there's the fiscal right there laid out for you. And there's kind of a couple options there. So the next, the third and final one, is the sort of increased tax on sports wagering. If you're probably familiar, sports gambling is exploding because it's really easy, right? You just gamble from your phone. separate conversation about the kind of long-term impact of that. That's probably something at some point people should start talking about, but here I'm just talking about the money associated with it. And you know, you can kind of see it, this is a lower amount of funding it would generate, but if again, we want to give you flexibility in those rooms, right? And so if for some reason the other two are not working, I think we should have some fallback options. And at the very least, you know, that $19.4 million would be enough to cover 988.
But again, a very normalized and socially accepted eviction.
Yes. So those are the options. So let's Steve, maybe kick it to you to have kind of the conversation about how we should frame it. But in general, my proposal is that we sort of lay out the options and say, if you want sustainable funding, if that's something you want to do, here are 4 options for you. So these 3 plus the cell phone fee that already is there. But then the target number, I guess the one question that's been raised by Zoe is what's included in that target number. So open to conversation about that.
I don't know if I necessarily have an agenda, but off the top, I think, you know, to Zoe's point, and they are legislators and leadership will ask for what's the number you're shooting for, and we'll have to justify it.
Sure.
I think it does make sense to separate, like we could have whatever the issues are that we decide to recommend in the commission report, but I think there is some logic in separating what we call Sentinel Deck 1 initiatives and the funding streams that go with those. And I think we can get pretty close to lining that up. And I like what you're doing in terms of options, and it almost becomes an Excel spreadsheet, right? You pick the one and then you change the percent and then you get to the number. But that's why I think we have to have the target number. So we have all these options. You can move the percentages around. We don't care, just so you get to that number. I also think, and this just becomes a political strategy thing, but there will be initiatives probably. The things we're trying to tax are probably going to want to do some kind of expansion, or at least some of them will. And the extent that we can tie those together can be a positive also. So like, if we hadn't passed happy hour, allowed happy hour, we could tie it to happy hour. And I think the people that might be opposed might be more willing to be supportive if we had that kind of a back and forth. So those would be my thoughts off the top.
Sure.
I like the opportunity for the options because I think it gives the idea of having a choice to make, because I don't see a couple of those options being successful. So it's almost like saying, okay, pick one. I think it makes it better that way.
Absolutely. Thank you.
And I want to just kind of get our legislators' feedback, but in the season of transition that we're in, I don't really foresee any tax passing. And so could a funding option be our budget needs to increase to support these initiatives? I think pulling out mental health and mental health services as a tax almost fuels the stigma of it, versus why are we not as a state owning in our budget and making it part of our budget to support those with mental health needs versus
Yeah,
a tax?
Great point. That's what I think, that it's a trade-off, right? And I think from our perspective, we should say we don't care. Like
Yeah.
either increase the appropriation or there's these other options.
Okay.
I don't think we should say definitely do this. I think it's sort of like we're laying out this target for you of this. You've asked us what it takes.
Mhm.
This is what it takes. Here's some options to get there. The rest is going to happen in the metaphorical smoke filter.
I'm good with that.
Right. Yeah. I mean, that's my take on it, instead of like trying to engineer kind of because you can't engineer session. It's like impossible. Right. So like instead of doing that, just sort of like, hey, whatever you want to do, that you've asked what it takes. This is what it takes. Here's the proof. Now can you?
So budget appropriation or a line item would be one of the options.
Absolutely.
one of
Yeah.
the 5
I think it has
options.
to be. Yeah.
And probably part of a mix, right?
Yeah,
I mean,
I
I think
yeah.
it's gonna end up, hopefully it's gonna end up being a mix of these
Yes.
things. And so while I don't disagree with what you said, Zoe, I think we do have a concern, or some of us have a concern, that relying on appropriation only is gonna be so cyclical, and I've been here long enough to know that sometimes it goes up and sometimes it goes down. And we need a solid infrastructure.
Yeah, and we can't, again, we can't discount the atmosphere currently, especially around kind of Medicaid. And so that's one thing I think anything with health and money next session is going to be looked at with, a lot of scrutiny.
When did we start allowing for alcohol sales on Sunday? Was that,
It was a couple of years.
has the adjustment not happened since then? So you're saying it was since
Oh, yeah.
1981?
It's been,
Okay.
it's been 40 some years.
So
yeah.
1981, so we've allowed now increased sales
And happy
7 days
hour.
a week and happy hour.
I see those wheels turning.
Yeah.
Sorry about
Just,
that. so-
due diligence here.
So these are all great points. What I'm hearing to kind of recap is everybody's cool with the idea of including options. So there's actually 5 options, right? Appropriation, and then these 4 options. We should have a target, and everybody's good with that target sort of being SEA 1 target and then everything else. Or maybe each individual item have, yeah.
How about appropriation plus an option?
Yeah, so yeah. Great, yeah. Appropriation is a no-brainer. And I think that our baseline should be the 50 million extra that we got last time. And that, I mean, again, that's, I don't even want to put that out in the universe, but that's just there. Like, we need to just sort of start with that assumption, and we should make that clear. So appropriation plus sustainable funding. And then the target should be SEA 1 target, and then the other recommendations, we can have individual sort of estimates, price tags, and maybe add them up at the end. Okay, that's a lot to put into a motion. Okay, sorry, yeah.
And sorry to add more, but some programs our provider consultation programs use a pooled insurance funding
Yeah,
model.
we'll get to
I
that.
don't know. Okay.
Yeah,
That
that's
makes
separate.
probably
Yeah.
small.
It's so
and
narrow.
separate.
Yeah.
Okay.
Yeah.
that's fair.
I mean, that should be a no brainer. And that should be one that I think, anyway, we'll get to that one when you talk about it, but yeah. Yeah, this is for the sort of big ticket items, right? All right, so the word salad I just had, if somebody could put into a motion,
Motion to
include all the funding options.
all the funding options plus request for appropriations.
Yeah, and then also include targets
With an exact target.
with target. Yeah, okay. Thank you. Appreciate it.
I'll second that.
All right. All in favor?
Aye.
All opposed? All right, that motion passes. We've got, I think, 3 recommendations now. So let's take a break here and then come back in at 10 o'clock for kind of part 2, which is we have a few other recommendations we want to mention, and then this is sort of round robin of other people. So, all right, thank you. See you in 5 minutes.
No, your other phone's under here.
Oh.
Partnership, not mothering.
Thank you, great job.
You've been out in the sun. What have you been doing?
Playing golf, playing grandkids on the field.
All the fun.
Yeah, it's going to baseball game.
Got a case on the side, yeah, because everything's changing, but. Congratulations, thanks on your outside. Yes. That's amazing. Yes, a lot of good change this. That is really great. Yeah, yeah. Yes, sure. I'm so proud of you. I'm super excited. Yeah. Yes. If you ever need anything. Oh, that's so great. I still got friends. That's so great. I do. When someone's like. I'm still thinking everything about you all, like, yeah, it is.
And so I will tell you, Representative, Chapel for Robin, her father's death, so I see you receive. Thoughts.
Absolutely, absolutely. And but I just.
Thank you so much.
Very, very proud.
Thank you.
Well,
Yeah, that's right. It's good to see you.
See you too.
Hi, how you doing? It's good to see you. Good to see you as well. How's your day? Wait, I was actually in Portugal. Really? Just relaxing. Nice. Escaping. How's your session been? Well, it's been pretty good. I didn't have a lot of work, but I got some. Remember the whole. Yes, that's so good. I don't know, just like, I never knew her to die. I mean, she was already just a brief application, but I don't know, it's like, it's a little bit. Yes, yeah, it'll be short and sweet. Yeah, start to chat. Yeah, awesome.
How have things been going in the world? Yeah, how are things going with just the rollout of the high school options? It feels like
Homeland Security does a lot of the computers and training.
actually be researcher just sent me like a attacking
Well, I think, yeah, I think that's my worry is like, I see, both sides, but I don't want to use like, 'cause I don't necessarily think it's like, I think there's a lot of good in it, but it's being framed very poorly.
Right, and you're not like, what's the problem in framing it? You know,
Yeah.
Because I'm anticipating that with this next iteration, of it comes out that all this feedback is gonna be taken into account. And so I'm hopeful that there's gonna
Yeah.
be, some shifting.
Yeah. Well, they put the official rule out, so I don't know if it's like pretty much what they said, was in it. But yeah, I think it's more just like the framing of it because, a lot of people are saying, well, it's, the bare minimum and there's no foreign language and all of that. But I don't see that, former school board, like, I don't think everyone's gonna just jump to students not taking, because that's not.
I feel like it
going to
just
be
is
applicable.
increasing flexibility.
Exactly.
And that's what I'm like, we actually want to.
We
have,
want,
like,
but yeah, because
we
like
want-
people complain all the time, like, why do we have to take quantitative reasoning junior, senior year? Or why do we have to take 3 years of foreign language? But now that we're giving that option, now people are bad. I'm like, yeah, make everybody happy. So I do think, some of the framing of it. And so we're working on some tools for the state board meeting. It's like next week. So I don't know how many of those are gonna be accomplished, but some FAQs.
And that's what I was wondering, like, is there like?
the base Friday night before.
Like, these are the vision seniors, but here's what we
Yeah.
consider best practices.
Yeah.
Or like,
Yeah.
like,
Areas
like
where
recommendations
around
for
how they make
counselors
that
to consider, or like, I just.
And so that's what we're working on, like student profiles. So it'd be examples of this is what this could look like for someone going straight to the workforce. This is what it would look like for a college-bound student. I think their intent with these new seals is to have more of a, like, if students are going on to four-year college, they're probably gonna take that courses, which brings that rigor. Experience. So I think it's, yeah, I think it's being misconstrued depending on which side of the you're on, which being, so, because I don't, I really don't, as an educator, there are some things that have to be like figured out, like points and credits and the tracking, like that is a lot. But I think when it comes to providing flexibility to students, right?
That's one thing.
Yes. So if you have just like one thing, they're right, probably to speak, but like.
There are some schools, like I have a friend in Maryland, which is a town. No, I don't know, it's by like Ohio, but they love it because a lot of their students do good.
Yeah,
But they're
that's,
getting
that's a
through.
load for you. isn't
They
it?
don't have to. Like, it allows them to be more. So.
Is your house
And I've been
golf
like
thing?
waiting for it to go in.
We have an event,
Last year, if I had
in Newburgh where I lived last night. So we were there. That's good.
I do not want to spend that about two, it's not a bill. I've just been like waiting for this to be like, it's just- yeah.
I know. She might be speaking it this year. But.
I'm leaving Friday for Alaska. Cruise.
I know,
and
but I'm-
And it's very directly, yeah, there are some students that algebra two and higher math have been learning to make it different. Question, for students, like, I was a more artsy, well, like, I love that,
Like I
Yeah.
the trick, like
and
I.
they're dance and then you.
Yeah. I just trying to figure out how to.
I think, I mean, my biggest thing when I've talked about just, I think the art and the world language, and I always laugh too, so I was a PE health teacher and those are all my license, and those are all the things that, like, and so, but I still think like there's still room, like this allows the students to now take strength and conditioning for basketball all 4 years. If they want, it's not, then they don't have to take PE1 just because that's what he said.
A lot of-
There are some
Oh, I know.
lessons provided. It's just how you frame it, and I think students are still going to take foreign language because if they're going to a four-year college or they're worldly or liberal art, like it's gonna be special. But I don't know, maybe not everybody thinks that way, because I also have my own.
Yeah, it's like a
Digital.
All right, let's get started.
Oh, yeah, those are things that
I
are.
like it.
It's just, I feel like my only thing.
There's like, you can upload it, like-
So many people's opinions, so, yeah.
We'll give David, sorry, we'll give David a minute or two. I thought he was here.
He went to get coffee.
Okay.
Should have followed.
I will never forget my water again, $3.05.
I
Wow.
know, it's ridiculous. There it is.
We never made it.
We could add water tax.
All right, Danica, we need money info on a water tax.
Yeah. The government building.
Yeah, only it's really narrow and targeted. You know. Pay for like one therapy session. All right, let's get started again. Thank you. So next slide. So we have a few recommendations. So Gina Woodward's here for workforce person that you've been hearing from. But before we jump into Gina, there's a few slides that we have that just kind of came from some various places that we just sort of think are good additions to what we've already been talking about. And so speaking of acronyms I don't like, because I want to say CHAMP, but this is a project that I'll let David maybe chime in on this. But this is a really, we're all aware of, and I think when you talk to school superintendents or you talk to, a lot of stakeholders, there's been a growing need of children with really high acuity needs. These are usually children who not only have kind of a lot of trauma and severe emotional disturbances, but also have usually corresponding intellectual disability. And these are kiddos that unfortunately end up in places like DCS offices or emergency rooms for, sometimes a while at a time. So in response to that, the executive branch, kind of led by the governor's office, has convened this project that David is a sort of member of the executive steering committee of. Has come up with several work streams, which again, this is not all of it. I think they're very humble about what they're trying to do here. They're not trying to solve this problem with this project. They're trying to do some things to move the ball down the field. And this will be memorialized, I believe, through some sort of executive action. But with the administration change coming up, we sort of felt like this should be memorialized somewhere else as well. So David, if you're comfortable, do you want to go ahead and talk about just the work streams and the project, and then we can talk about it more?
Sure, happy to. So it's been really intentional work happening in this space for a couple of years now. Trying to make sure we stay ahead of where other states are with having, a number of kids in inappropriate placements short term. We occasionally run into that issue and try to find ways to respond. And this has been, again, an effort to try to address that population of these higher acuity youth, make sure they have their needs met. I've been very involved in the second work stream there, the intensive foster care and respite. I talked about that a little bit during our last commission meeting. That program is designed to try to keep these higher acuity kids in the community with families, whoever that family is. We are not trying to create new foster parents who have special training to take care of these kids. In fact, trying to bring the training and expertise and resources to wherever the child is now. Because we know really clearly in the research that moving kids around is not good. Our goal is that kids have placement stability and that they are safe. And so that program really is designed to, again, bring in those expert resources and services to wherever the child is, be that relative care, foster care, kinship care, wherever that child is. The gatekeeper process review has been something we talked about a lot. The gatekeeper, the name we don't really like. Trying to find ways to maybe label what that person does, but trying to find ways again to ensure that our youth that have these really intensive high acuity needs are able to get resources, including state hospitalization when necessary. There can be real challenges in trying to get youth who need hospitalized into those programs. The transitional homes and family coaching, that's kind of a new name for that work stream as well, is just what it sounds like. So trying to find resources that are residential for some youth who have needs who just cannot be maintained in their own homes. And we know there are youth like that out there. Our goal is that they are in those programs short term. Same with hospitalization, that it's more crisis stabilization. The family can learn how to respond to the needs of that child while they're in the transitional home. That's the family coaching part, and then get back into their own homes as quickly as possible, and maybe utilize the respite care that's included in the intensive foster and respite care services. The Cross Agency Navigator program, that's again just trying to make sure that youth are connected to resources, because it can be really complicated to know, what all youth are eligible for, making sure they've actually completed the application, making sure that all the resources that are available are in place. So that role is more to make sure that there's some coordination happening for these higher acuity, because oftentimes we still see that. So the youth haven't had their needs met along the way, and now they're in crisis, and they could have been in this service or in that service, but there was a lack of awareness. So trying to make sure we have a better understanding of what's available. So happy to take any questions anyone has about the work. It's been, again, 2 years in the making. We've had a number of improvement opportunities we discussed. In fact, I think there's 36 that we came up with. So like Jay was saying, trying to zero in on what makes the most sense this time of transition. It's been a challenge as well. Yes.
Thank you, David. Couple questions. And I'm increasingly getting more constituent inquiries about where do I place my child? I'm having to send, law enforcement's been involved, they have these short-term stays, et cetera, et cetera.
Yeah.
And so do we have any specific data regarding state hospital placements that you could provide?
We do. We, through this work group, have done a lot of discussions around state hospitalization and usage and the admission process and whatnot. So we do know there's a need for more state hospitalization beds as well, because there's currently a wait list for some of those programs. And what you're describing, yeah, we are experiencing as well. Families calling us, wanting to know what they can find to meet the needs of their child. So I think that's part of our charge as well, is making sure that collectively helping create systems so the families can get their youth needs met, that come into the Department of Child Services to have to do that. So
And then these aren't all specifically, or these aren't all Medicaid specific, correct?
they're not, no,
Oh,
correct.
yeah.
Yeah, for sure. Certainly Medicaid's a key resource for a lot of these youth, but not all, and certainly we can use them.
Do you have a number about how many youth would be in that Medicaid bucket?
That we've staffed, because there's another component to this work called the Rapid Response Team,
Yeah.
where if there is a high acuity youth who is in crisis that needs additional resources or expertise, we can all come together and staff that youth kind of at a moment's notice and make recommendations and connect them to resources. How many of those youth have Medicaid? It's a high percentage, certainly. I don't off the top of my head what that number is.
That'd be interesting to know, to extrapolate that out. So again, as we're talking about
Absolutely.
sense and all of that, I think it's important for people to know that our children that are, low income are struggling.
Right. We've seen some private insurance cases as well come up. We've tried to get creative for those youth as well. But yeah, for sure, there's a high percentage of youth that have Medicaid as their health insurance.
So just to clarify, so you do think there's a shortage of beds, state hospital beds for kids?
There certainly appears to be, yeah.
That's always been.
I think, yeah, I
So
think,
I-
and we'll actually get to this on a slide here. So I can say now, I guess the biggest, it's, so there's a shortage of places that we have some degree of control over. Right. That's, I think, the best way to put it. It's the state hospitals. Again, I say this as person running state hospitals, are a very appropriate place for some children. They're not an appropriate place for children to stay a long time. Right. But the reason they become the default is because we control it. Right. So what we're going to get to, and this is another thing that the group talked about, but maybe didn't make in their number one first thing, is the concept of sort of like no eject reject, which is something that really, if you zoom out, I mean, it's a sort of a buzz phrase, right? What that means is something that so it's sort of a pressure release valve, right, for the rest of the system. And so the state hospitals are part of that, are definitely serve that function. Like sometimes you just need a place to have some place for somebody to go, the kid to go, to let things calm down, to let the family get stable, let the kid get stable. And so that's where I think the state hospitals are definitely a big part of it, but they're not all of it, not the least of which because they're really expensive.
Jay, I
Yeah.
think Representative brought up a good point, and if there is something that can be done through this report, Medicaid lives matter, and a lot of those Medicaid lives are our children. And if with Medicaid cuts and the Medicaid, I think we need to elevate Medicaid lives matter in the state of Indiana, and that is really our youth. So if we can elevate that in this messaging, that's who's going to be impacted by these cuts.
Yeah, like reframe the conversation.
Particularly our foster
Yeah.
youth.
For sure. I think the whole system has some gaps, right? I mean, there's some gaps in outpatient intensive services. How do we fill those gaps? Residential, acute, subacute. These are all areas that can be challenging to get youth into. And while they're waiting, they usually are getting worse. So how do we get them into programs more quickly so they can get better more quickly? That's what the goal
Absolutely.
is.
And the group has done a lot of work and so I think that the ask would be, I think, and one of the things you all are talking about right now is kind of what, if anything, is going to go into your kind of legislative and budget asks for next session. And so I sort of would ask that we at least have this as a place for this work to live, be memorialized, and as well as any kind of additional, and we can as that work continues, we'll have a chance to review it. But that's the reason that we wanted to bring this up was that this is ongoing work that's not final by any means, but I think it would be a missed opportunity to not include this particular important project in our.
Yeah, I certainly agree with that. I met earlier this week with one of the juvenile court judges, and we talked about JDAI and what we're trying to do with that statewide. And so unfortunately, a lot of kids do end up in the correction system where they do receive some of the services that they actually needed. It would certainly be nice to have facilities or places for schools and others to send these kids that are so dysregulated, they're causing huge issues. I think when I talk to my school superintendents who I meet with monthly, and Jay came to one of the meetings, several of them are trying to put together cooperatives right now to have a place to send a student that's dysregulating and causing such a disruption to the learning environment in the classroom. And so if we can make this a bigger conversation where we really are thinking about all the touch points and all the aspects that might impact a child that's in this space, certainly we have tried, and I've tried as a legislator to think of ways to get more robust treatment opportunities into school systems and things. It's a difficult conversation at times, but Jay just said it, I think, and somebody said it, the earlier we can touch these kids and begin to put them on a path to wellness, the better the outcome for everybody involved.
My earlier point too about the clients being parents. If we're better responding to the parents, we're going to have healthier kids. I think that's really important that we look at that as an investment as well, because we know our kids need caregivers that are healthy.
Dr. Yoder?
Yeah, and I'll share this later, but I wanted to point out that for this population, we heard from in the child focus meeting, the multisystemic therapy, that's really, emphasized.
Yeah, absolutely. Yeah. So this is kind of one of several, I think, children specific recommendations that we're going to talk about. But, so if maybe we can get a motion to incorporate the CHANT
So
the word and maybe recommend a different acronym. And I'm joking about that, but yeah, include this work in our final report, and we'll again work with David and those folks to kind of flesh that out. So second,
I'll make that.
second. All right, all in favor?
Aye.
All opposed. Okay. All right, moving on. So this is the other piece of this, which and this is where how I think this makes sense to phrase it. So that we heard a lot about this, and I think it's really important. We have to simplify, right? What we're talking about is a continuum. Right. That's and one of the maxims of working in human services is anybody you talk to, the most important part of the continuum is the one they're directly in contact with. And the truth is that when you zoom out, look at it system level, every part of the continuum has to be strong, or you'll end up with problems in other places. Right. And so I just wanted to kind of like talk about these are some of the things we talked about throughout this. And so the reason all these words are there for a reason. Sort of systematically, it just is a nod to the notion that we're not going to be able to do this in one session or one budget session. This is sort of like a long-term commitment that needs to be made by everybody involved. And that's, I think, something that's animated the high acuity children's work as well. This is not something we're going to be able to do right away. And other states that have made progress, New Jersey, for example, did this over a period of 19 years. Under a court order, right? So this is like a really, really big long-term commitment, but it's one that I think we need to make. So I think sort of systematically bolstering every part of the continuum kind of systematically is where we need to get to. And it does kind of link up with some of the other things we're talking about, right? So the things with CCBHC and crisis response are lifespan things. So there are children specific crisis response initiatives that we heard a little bit about, as well as children-specific services within CCBHC, including school-based services that will help this. So on the outpatient side, it's that piece of it. We learned about the school mental health framework, and we can kind of reshare those slides if folks want to learn more about it. But this is to your point, Senator Kreider, of like, can we give at least the very least our schools tools to incorporate this work into them? And so that's that part of the continuum. Then the one, maybe Zoe, if you had mentioned this, but I think this is important. I know this is something that you know, because we all share the goal, I think, of children should live in the community and in homes if possible, right? But there are situations where the pressure builds up so much within the system, and this is the rapid response team, right? Where there's just nowhere else for these children to go. And we only have the state hospitals right now as that pressure release valve, and we're full. I mean, we have a 4-week waiting list for children right now. So the one thing, and maybe David, I know you have opinions on this, you share them, the sort of no eject, reject residential beds is something other states have done, I think, to varying degrees of success. I don't think certainly has not been a silver bullet by any means, but what this concept is a higher rate for these facilities in exchange for essentially a promise not to reject children that are referred. And when children are there, not to eject them. No, it's a really high intensive thing where it's like, there's problems with the milieu, there's problems with the other, there's definitely things that this is a trade-off. This is not a silver bullet, but I think it's something we have to consider. So I'll let you, David, if you want to chime in on.
I think that's well said. I mean, I think we gotta be very careful about it, to make sure that all of our kids are safe. Because if we just have a program that cannot say no to whoever we refer, what will that milieu look like? And we should be very careful about the parameters of who they cannot say no to. So as long as that is well established, like what the diagnosis is, what the presentation of the youth is, to ensure that the milieu remains safe, that's what I would be concerned about. And then the no eject. Well, what does that mean exactly? We don't want kids just growing up in a facility because you can't discharge them. We gotta make sure we're thoughtful about that as well, that we are intentionally planning, to your earlier point, of getting kids back into communities as soon as they're ready to go back to the community. We're not gonna put kids in a facility and forget about them. That's not something we should ever do. So it has some value. I could see appeal. We have a lot of people. I wish I could find someone who couldn't say no to this kid, because right now where they are is not sustainable. But again, I think it requires us being very thoughtful about how we implement that.
So I'm wondering if actually, I think what we need is, so this is related to state hospitals, but I think what we actually need is a sort of very targeted increase in the amount of no eject, reject places, right? This is not whether that's residential or it's state hospital beds
Or even respite beds or crisis
Sure.
beds. Like, I think, coming from residential settings, as an operator, I would not be able to operate under a no eject, reject residential bed milieu. My staff would leave, my patients, families would be in my office. So I think that wording we need to maybe reframe a little bit, but we do need to, also coming from that setting and being one that said no quite a bit, we do need people to say yes, right? And so how do we?
Oh, and that's what happens, right? Because like
Right.
everybody's like, oh, well, somebody else will deal with it. And then all of a sudden you realize you have these children
Yeah.
who actually don't belong in state hospital settings
Right.
that are go into these state hospital settings. And it's like, there has to be somebody that is incentivized very strongly to say yes.
I do, one of my cautions though, is I do worry about bad actors. Because as the reimbursement is very significant. Yeah, so I think the contracting criteria would need to be very tight and the oversight would need to be there and established.
I'm wondering if we just sort of consider this and lay out the problem as opposed to maybe, go ahead.
I would like to see it tied to, if there is going to be increase, that those facilities use multi-systemic therapy. Because one of the reasons why my facility at home stopped taking those children is because when they're discharged right back into that home environment. And it does not, there's no benefit,
Absolutely.
there's no outcome.
You're absolutely right.
So David, would this accommodate students that are currently in other states because we don't have appropriate, are those students so acute that we're probably not going to have the ability to handle them?
Let me be clear, we don't have that many youth that are placed out of state. Most of the ones that we have placed out of state for DCS are because that's where their family is, or there's a relative there, or they're right across the border.
Well, I have schools that tell me that they have, real difficulty because they're responsible for transporting parents out to visit schools and other states and things. And so I don't know of what exactly circumstances are because we don't.
So
Get into-
I think if there's a silver lining, which is you have to stretch, right, to find one in this situation, is that the volume is not that high that we're talking about, right? I mean, that's I think like, but the problem is every single one of these situations just is really intense, really expensive, and causes issues across the board, right? It causes issues at DCS, causes issues at schools, it causes issues at the state hospital, causes issues at CMHCs, it causes issues at the home. Like, so, when we're talking about sort of whether no reject or state hospitals, we're not talking about an increase of hundreds of places. We're talking about an increase of estimating, 5 to 8, right? Or 8 to 12. Like, if this is not like a massive volume here. I maybe you disagree, but I don't think we're not talking about like a lot of things. We're just talking about like a little, I like the pressure release valve analogy. Just at some point that it just needs to be released and everybody needs to be able to breathe.
I completely agree with all of that.
Yeah.
And I will say the intensive foster care program a little while ago, actually to your earlier point, will start paying per diem to a caregiver while the youth is still residential, to get them engaged in the treatment while they're still there and doing active discharge planning so that bed doesn't get lost to somebody else. They're going to pay to keep that bed open for that youth who's going to be discharged hopefully the next number of weeks, which is very unique for us. And then hopefully we'll have a much more streamlined discharge. In the past, what we've done is wait for the kid to be stabilized and then try and find foster care. And that's hard because the youth on paper are really challenging. So they'll be in residential for weeks or months waiting for a home to be found. And during that time, they're regressing. And so that's a real problem. So with this, we'll be able to have a caregiver identify where that is, be it an aunt, a grandma, somebody who can take care of this kid with the right supports, start paying them to get engaged in the treatment. We can discharge the moment they're ready. And hopefully be able to have that family-based service stay in place so that the home really has changed. Youth doesn't come back into that more intensive program.
Any other comments on this particular piece of it?
Well, I hate to say this, but I'll say it. So, just because I'll feel guilty if I don't. I love that, David, and I think that's the absolute best solution. However, I do worry about the optics as we've cut family caregiver services in other areas. And so I would hate the public to perceive that we're picking and choosing who's more important. We talk about the congruency with IDD. And so I just, I think that narrative and threading that needle has to be really delicate. But it is the best evidence-based approach. I mean, without question, but I think in this time where, the water is boiling, we got to be mindful of that.
So, and this always happens with this particular conversation, to be clear. This is because there's no right answer, I think, in this situation. I think we're just torn between kind of two irreconcilable points, which is like, the kids belong in the community, but also like sometimes it's not feasible, right? Those are the 2 points that are like just at tension with each other. As far as a recommendation on this particular point, and this is sort of the one of them that I thought would be a little controversial. Why don't we just talk about it and sort of maybe stop short of making a recommendation on this particular piece of it? Like, because you're just going to go circular round and round with these conversations. But I think we have an obligation to call out this problem. Right? Is that too kind of wishy-washy? Like, should we go stronger? I'm open to pushback there.
Are you saying about all of them?
No, just about the no reject region.
My challenge is I think about carrying a bill that has recommendations, or if there's a recommendation. There's no way in a committee meeting you can have this discussion.
Yeah.
I mean, you would have so many people show up that had various thoughts and ideas, and from education, from corrections, from you name it, that it would be nearly impossible to like try to sell an idea. This is a solution. I just don't see it being feasible. I do think it's good to talk about. I do think it's good. that people see that that's something that we considered as a commission as we prepared a final report. It'll make a lot of people feel like somebody's listening, at least paying attention, but I mean, if you took that issue and even filed a bill separately, it's really almost impossible
I agree.
to move it through the system.
What if it was framed more around the no eject, reject continuum of care versus just specifically on that residential bed component? Because I think everyone could get behind the continuum of care and being supported, because it might not be a residential bed. It could be respite. It could be maybe partial. Maybe this is our opportunity to highlight bringing day treatment back, which maybe more framing more broadly versus the residential bed.
I think that's the right move.
And this could actually nest pretty easily, I think, underneath the high acuity work.
And could a lower level be something like a review of their guidelines, of eject, reject guidelines and lower recommendations around that?
Modernization.
Right.
Just,
Yeah.
maybe we already know exactly who says what and when, but
I mean, there are other states that have these kind of contracts in place with some mixed results.
Mixed results.
Just being very clear about that. So to be very careful about how we implement something like that, because it's gonna have consequences, good and bad. So.
Yeah.
Yeah, that's why I think that that there just needs to be a deeper study and conversation so that we really are getting strong parameters out. And so I don't think that we're at a place to make any type of recommendation until we've really studied what other states have done, what those results have been, and gotten input from providers on what they would like to see in terms of those parameters as well. I don't think we're at
Yeah.
a place.
So I think I agree. I think it's important to mention this tension in our report, because I think there's value in just elevating this conversation and pulling it out, frankly, because this is this thing. Every piece of what we're doing here has some of like core tensions that, and I think this is a sort of analogous tension to like the overall concept of like involuntary commitment versus voluntary. I mean, so there are all these tensions here. I think it's important to pull them out. So I think maybe what we'll just do, instead of having a recommendation on this one, we'll just try to incorporate this discussion into the overall, and we'll figure out the right way to frame it. Does that work? And then the other ones, the only thing I think we need, we'll talk about parity. I think Steve can talk about parity later. We're talking about now, but the only voting item here is how do we feel about sort of promoting the comprehensive school mental health framework in our report? Are there discussions about that?
I think it 100% needs to be as an access point listed for the commission.
And MST is going to come up later, so we'll talk about it. Any objections to including it? I guess we have a motion.
A motion to include the comprehensive school mental health framework into the final report.
Yes.
Somebody.
Second. All in favor?
Aye.
Opposed? All right. I guess, Steve, this is a good point to talk about parity.
Okay,
Do you want to bring it up?
I can. I didn't have a slide.
No, that's fine.
So as a reminder, Indiana had passed legislation on mental health parity actually before Congress did. Just FYI, if people didn't know that. Very proud of that. Senator Cryer had a bill, I think in 20. We're all very proud of all the work that we're doing in the parity perspective. I chair a subcommittee, the Mental Health Task Force, and the Department of Insurance did an audit as to compliance. And within the technicalities of the statute, everybody was in compliance. But there do seem to be some areas where there's difficulty, and we heard testimony at one of the hearings from IU Hospital, where they talked about provider reimbursement on the mental health side being less than, which affects workforce and affects access for patients. And we also, I don't want to speak for you, Representative Ledbetter, but I will, and then you can add to this, but there are providers where they think they're in network, but when it's carved out to a contractor that's not in network, and so then parity doesn't apply. So I talked to some of the national parity leaders, and they recommended, so for topic for conversation here, they recommended that we have legislation that does two things. One, it would require provider reimbursement parity, and the way they recommended doing it was tying it to Medicare rates. That if you do 10% plus or minus on a Medicare rate, you want to give a range so that insurers do have the ability to be flexible. But if you tie it to Medicare rates, the physical side, they're going to get the Medicare rate. If we're mental health sides within the Medicare rate, then we're going to have parity. And then with respect to Representative Ledbetter's issue, we can deem any carve out, mental health carve out, to be part of the network and require that parity is complied with. So up for discussion would be those two recommendations.
I would just like to add, I think that's a great step forward. I just want to recognize when we discuss parity, it shouldn't be only about just the provider, but about the consumer. So these people that I'm seeing that don't realize that they're out of network, their copay goes from being $20 to $100. And that we ensure that the copays are the same, the 80-20, the percentages are the same, those types of things.
Yep.
And my participation with Steve and others with DOI after passing that bill left me very frustrated, I guess I would say. Insurance companies do not describe systems of care the same way. They don't have the same definitions and things. It's really nearly impossible to measure them against each other, or even whether they're trying to comply with the Federal Mental Health Parity Act. And so looking at it from the payment perspective, to me, makes a lot of sense to do that so that we can understand whether they're even trying to comply. Fascinating discussions and lots of new acronyms and new terms to learn. And to their credit, I think the insurance company sent kind of their best people to be engaged in that discussion, but it was really pretty frustrating to be part of. So
I'm really, oh gosh, I lost my train of thought. When I was reviewing what other states have passed, and you talked about the audit. There are states that have fined insurance companies several $1,000s for not following that Parity Act. You don't necessarily want to take it that far, but that's always an option.
So, and I wasn't going to mention this, but since you did, I will. The federal and state parity acts do not have a enforcement mechanism. And Department of Insurance could be empowered to be that if you wanted to empower them to ensure compliance.
I think if you did that, they would need people, like more people, but yeah, I agree.
I'm wondering along the lines of parity, Steve, as far as payment, I also see it as an opportunity for administrative burden and parity along those lines, because whether it be the client or the provider, to get mental health services from an administrative burden standpoint is very different than when I go to get my heart or anything else checked out. So I wonder if we could align, and just also knowing in this transition, administrative burden is definitely something that will be a priority. If we could use this opportunity to also not only payer, but administrative burden parity and fairness, because that's where people are impacted.
I will say that changing that contract when they subcontract out the mental health is going to relieve a lot of administrative burden on office managers.
Yeah.
So to kind of recap where we are, it sounds like the specific suggestions are indexed to Medicare. And so you've got language and you've got some language that we can kind of combine into one recommendation. Sort of consider the carve outs to be in network, which I think will be fun to talk about. And then the other two are are important, I think, to mention, but I don't know how to turn them into a specific recommendation, which is sort of make sure we're considering the out-of-pocket amounts that consumers are paying. And then I guess three other things: consider that out-of-pocket amounts that consumers are paying, consider administrative burden, which again, I agree with. I think it's harder to kind of memorialize into a legislative recommendation. And then consider giving enforcement authority to DOI. So two specific ones and then sort of three considerations.
And I'll just, if it makes you feel any better, if we do deem it to be compliant, when they do the carve out, if we deem it part of the to come under the Parity Act, all the requirements, the out of pocket and all that would naturally flow. So I think we could mention it, but I just want you to know that would be taken care of. And I agree with your point too, to Zoe, that the reason why the administration is so difficult is because they do carve it out to a different entity, and then that just becomes its own thing. And so I think these two things would take care of a lot of it. Obviously, a new governor is going to have an opinion about the Department of Insurance.
We can help.
I'll just say that Department of Insurance does ensure compliance for everything else the insurance companies do. So just throwing that out there.
Yeah.
You want to start off with a bang?
Yeah. Well, yeah. I mean, that's,
Doesn't mean it's staying.
Steve, just one thing, also knowing federally things are going to be in transition. Did your national context and parity have any concern with Medicare rates going down and Medicare being impacted? And then we are tying these rates to parity and Medicare. Is that a concern that we should be aware of?
But if they go down, everything goes down. So you still have parity.
Okay.
I mean,
that's all we can do.
It's yes, there's a reimbursement issue, but the parity issue.
Right.
It could be crappy parity, but it's still parity. Okay, so again, word salad here, but how do we, can we get a motion to consider parity recommendation to index to Medicare, consider carve outs in network? And then those other three considerations as more discussion.
I will make a motion for mental health parity to tie it to Medicare, for the carve outs.
That's it. Second. All in favor?
Aye.
Opposed? All right. Okay, moving on. Gina, we're almost ready for you, I promise. I feel like we're just always, I think this is the last thing. Okay. This is not, don't worry about reading the slide. This is more of a visual, but a little bit of fortunate timing here because everybody talked about Medicaid rates. Riley in particular was saying, they lose however much, $1 or $2 for every dollar they spend, because in large part due to the Medicaid rate reimbursement. For the first time ever last year, FSSA published the Medicaid rate matrix, which is a sort of dependable, regular schedule of Medicaid rate reviews and increases. I mean, not guaranteed increase, but a review that kind of takes into account actual costs as well as reasonable margins. As it happens, next up on the list is behavioral health rates. So rather than try to make some big push to increase Medicaid just for behavioral health, which again, we know is going to be a conversation, can we just instead recommend that the General Assembly and the administration allow and fund the Medicaid rate matrix work to continue into next session? Does that distinction make sense?
Yeah, I think it's the same thing to do.
I think what I learned from Medicaid when the shortfall happened is that they paused this rate matrix and that they were going to do the review, but then not put rates in place necessarily. So we can
go a step further.
So we need to go.
Yeah, I agree. I agree with that. That's yes. Okay. So do the review and also implement the results of the review, right?
Yes.
But I just, again, rather than demanding increased rates, say, hey, this is already happening. Let's just let it happen.
Motion.
Second.
All in favor?
Aye.
Aye. All right, I believe Gina's up now, right? Okay, all right, Gina, finally your time to shine. I feel like every time we've had her just wait and wait and wait. Gina, as most of you know, is our workforce director and has, I think, again, some really good targeted recommendations. You just for reference, Gina was on the kind of advisory group for that Bowen Center playbook that many folks were familiar with. And so some of this is drawn from there, although I think we're not trying to, be redundant to them.
Yes, that is fair. Okay, we can move forward. So starting off with the slide, you've all seen this before. First Behavioral Health Commission meeting of this convening. We started with this when we were talking workforce. And I just think, again, it speaks to the idea that without people to do the work, we can brainstorm in this space and we can problem solve, but provision of service is dependent on highly qualified, highly passionate individuals to do the work. So that's where the workforce piece comes into this. I think the important fact of this is to remind everyone that this comes from the 2022 commission report, and we're still kind of sitting with the same recommendation and the same emphasis of priority at this point in time. So I think moving this forward, we need to start looking at how do we take this really big, overwhelming issue? It seems really simple. There's nothing simple about it. So how do we take this and start to implement some small steps forward in making change? So we can go to the next. So again, to summarize some of the things that we learned from the first iteration of this commission, identified priorities that came through and common themes that we learned about was a need to look at and eliminating barriers to licensure, addressing the impact of the cost of higher education, as well as wages on recruitment and retention. And then the overall goal to strengthen behavioral health talent pipeline and pathways to practice. And I think to put these into kind of some simplified terms where our priorities live, we have to be innovative and we have to be collaborative. There's not one of these recommendations that lives with one organization, one agency. It's not a single responsibility. We have to be able to collaborate. It really has to go beyond us just understanding what everybody's doing in this space, but working together so that there's some consistency. And so each one of these recommendations ties into our emphasis on education and training, increased and intentional recruitment, and then retention that leans in on workforce wellness. How do we ensure that we're taking care of our workforce as a system? And so that's where we're going to dive into some potential recommendations for consideration. I think my role here is to kind of stage the conversation and allow you all to kind of look at what some of these options are and where's the space for us to make some change. But we're going to start with the first space where we zoom out quite a bit and talk about that collaboration piece. So Jay mentioned there are a number of folks who are talking about this work, who are engaged in this work. We have state level agencies, the Commission for Higher Education, who sends us this information, and I'll kind of tie that string together in just a moment. But Commission for Higher Education, Division of Workforce Development, the Department of Education, Governor's Workforce Cabinet, Department of Health, Department of Division of Mental Health and Addiction, like we are all talking about this. We're all putting strategy in place around workforce development. So this comes to us as an example from our partners at the Commission for Higher Education. And the reason I wanted to share this with you is there is an intense need for us to ensure that behavioral health and human services is part of our statewide discussion around workforce development, because it is competitive. If we're left out of the discussion, it's even harder for us to grow our workforce. So the relationship to this slide, this kind of identifies the priorities set by the Commission for Higher Education, helps us articulate one of the ways for us to look at this. So with enrollment, we know that our college going rate of Hoosier students graduating from college is somewhere around 53%. That's down about 10% in the last 5 years. So 5 out of 10 Hoosier students go to college. It's competitive. When we're looking at recruiting individuals going into career fields requiring a degree, it's competitive. The other 5 of the 10 who don't go to college are also in this competitive pool of folks where in education, higher education, workforce, economic development, our state is heavily focused on entry-level talent pipeline development. Things like stackable credentials that get your foot in the door in a different career space. For us, that's very difficult because we don't have a well-articulated early workforce pipeline. That's why collaboration is so important. So a potential consideration here would be, how do we ensure that behavioral health and human services is intentionally and consistently part of the discussion that we have at the state level around workforce development. An example of that would be when we're looking at prioritized career fields in our state, is there a social impact measure that's included in how we prioritize those careers? There's a number of these types of suggestions that we can make around collaboration. That's a rabbit hole that I love going down, but takes a lot more time than we've got. And I'm happy to have that conversation with anybody, but I know Michelle Clark and I from Department of Ed talk about this stuff on a regular basis. There's lots of opportunity here, but I think we start with ensuring that behavioral health and human services is consistently represented in state level discussions around workforce development and strategy. So that's my zoomed out version. We're going to dig in now a little bit further into more detailed recommendations. And these recommendations are representative of feedback from all of those partnerships that we just kind of mentioned, Bowen Center, some work by the health department and some other folks. So you can go ahead and switch. When we talk about eliminating barriers to licensure, we hear a lot of feedback, both from the field providers and from our partners at PLA about some of those barriers that exist. So recommendation 1 is improving the articulation of statute that guides licensing. So for the behavioral health and human services guidelines, at the mid-level for us, so that initial licensed clinician space, there's 4 different license types. The language is not consistent across the license types. The professions kind of see their scopes of work slightly differently, and they're not always well articulated in statute around license. So there's a lot of room to clear up some of those inefficiencies. One of the examples that has been named a couple of times in the mental health, addictions, counseling, and marriage and family, there's actually references to coursework. That's really difficult for you to represent in PLA's version because courses can be titled differently at different institutions. If the title doesn't match, you have to dig in a step further and look at like the articulation of the class and what content they're actually taking. So it's a major burden. So looking at that language and really simplifying that statute, cleaning up that code could be really helpful. Number 2 on the list is ensuring that our licensing board and agency have the capacity to do this work and ensure that there is staff available that is skilled in the evaluation process, eliminate those high wait times that folks run up against when they apply for a license, the delay in having that application go through the steps that are required. And then the third piece is reviewing timelines that relate to things like temporary licensure, reciprocity, and then eligibility to provide reimbursable services. So that relates more to what a service provider is allowed to do based on their time, experience, level of license. Zoe and I met with folks from there and learned about the importance of having initial applicants apply for a temporary permit so that their services are reimbursable immediately versus waiting until their full license comes through. That kind of guidance can be better articulated in the structures that we have in place. You can go ahead and go to next. So when we talk about the high cost of higher education, we're just going to lean in on kind of Jay's previous recommendation around looking at the Medicaid rate reimbursement matrix as a way for us to improve that scenario, as well as the information that you heard from Lindsay this morning for us in within the safety net system around CCBHC and how that's going to impact our ability to address wage. We also want to make sure that in those conversations, we're being very intentional about including roles for treatment extenders. So not necessarily just licensed clinicians, but also our community health workers, anywhere where we do have room to engage in entry-level workforce, as well as the importance of our certified peer support professionals as part of that dialogue so that they're not left out. We don't want the gaps in our non-licensed positions to remain or increase as we're elevating others. So that's important for us to look at. The other thing that DMHA has been really engaged with all of these partners that we mentioned is that idea of better promoting the pathways, better promoting careers in this space. We've talked about reducing the stigma around working in mental health and behavioral health. Sometimes there are misconceptions that we have an opportunity to really elevate those stories from providers who have worked in this space for a long time and love the work and would never want to do anything else. We want that to be the lead-in story versus some of the misconceptions and challenges that exist. So we are working in that space as well as many of the other folks that I mentioned. I think that the work that the Bowen Center did with the playbook has done a really nice job of helping us elevate this dialogue. And so we'll continue to kind of lean in on the work that they've done and help carry the torch from here. But again, when I mentioned it's competitive, recruitment for professional fields in our state and in every state is competitive. So we have to be smart about how we are bringing people to the field. And then last, again, this is my soapbox I'm always standing on, strengthen the behavioral health and human services talent pipeline, including pathways to practice. There's a good amount of discussion in the education space in our state around how students graduate from high school and what that graduation looks like for them in next steps, be it career pathways to work or educational pathways to higher ed. We need to make sure that we have effective high school graduation pathways that help students who are interested in the behavioral health space move in that direction. Sometimes that's challenging. There are a variety of reasons of why we're trying to improve it, but that is an area where we can focus on articulating those kind of expectations that we have as a state to be included in that discussion. Bowen Center also elevated a lot of information that supports the idea of looking at how supervision in our field impacts retention in particular. We feel the narrative suggests that we lose a lot of professionals in this field, not only due to that sense of feeling overwhelmed from the supervisor's point, but new to the field, not feeling like supervisors have the skill set they need to be effective in guiding and mentoring. So that's something that we can easily address on both ends of that spectrum, but Indiana doesn't have specific guidelines around credentialing, certifying, or training supervisors. So there's an opportunity for us to look at that as a potential solution, including in the establishment of supervision standards. And again, I will say not just with our licensed clinicians, but also with our treatment extenders. So for peers and peer supervision, that would apply entry-level scope of work for folks who are over those folks, and making sure that there's a true understanding of what it takes to support those positions across the entire continuum of workforce. So that's a lot of kind of general ideas and thoughts to think about, hopefully looped under the umbrella for everyone of that, remaining focused on the need to increase that big picture inclusion of our field in state level strategy, but also looking at some options for things that could be included as recommendations for this group as well.
Gina, I love everything you just said, especially theme 3. The only tweak I would add, and I don't know if you're allowed to do this, but
Where we want.
I can ask Jay, he can usually.
You can do it.
This all works if reimbursement's tied to it. It doesn't if it's not. And so like if we could say that we would tie reimbursement to all these different things that we're trying to achieve, the certifications or the supervision or whatever.
Yeah.
You know, I think that's the key.
I appreciate that inclusion, and I think Jay's duly noted, correct? We agree. I mean, obviously people have to be paid a living wage for us to recommend they work in a field. It doesn't matter what the field is. And so we have to start there. So I agree with you 100%. Yeah.
It's a similar concept to, tying reimbursement to evidence-based practices, right? Where it's like,
Right.
You can say you promote it, but if you don't actually tie money to it, is it really going to happen?
Gina, as always, amazing work. Just a couple things that I want to make sure that maybe we call out in this report outside of code and cleaning that up. The practices currently that are taking place with the Behavioral Health Board and IPLA, as far as sending our workforce to the Attorney General's office for investigation for not practicing because of using the word therapeutic services or other things. Last Behavioral Health Board, 40 behavioral health workforce were sent to the Attorney General. You're talking about competitive workforce, and we're sending an AG letter to a staff that's trying to get licensed. We need to call attention to supportive practices in getting our workforce license, not punitive within the code. And then also OT needs to be a treatment extender, not just peer. And we have seen many states who have been successful with OT, and back in the day, it was part of behavioral health. Being someone who benefited from extensive OT, I think listing that as a treatment extender should be included. And then tying back to what Steve said about supervision, funding for supervision. So a lot of folks provide supervision at no cost. CMHCs are one of the highest ones to provide that extensive supervision and are not reimbursed for that. And some have to pay for their supervision.
Yeah.
So coming out of school and having to pay for that, I think we need to show that support. And then the funds that licensed folks do put in, instead of going to the general fund, we passed legislation several years ago, Steve, I don't know if you remember, but for loan forgiveness for behavioral health, and it has not been refunded. That money was quickly spent. Those fees should be going to pay for loan forgiveness to supporting our workforce.
I did not pay Zoe to give the remarks about occupational therapy. I just need to go on record about that. But you obviously know this has been my, advocacy since 2016, and it is now well proven in 20 plus states. So I'm excited for us to take the next step forward. The question about, or the point number 2, which is so well stated, this is a real issue across healthcare. And I know we're specifically talking about behavioral health, but to meet productivity standards, to be the clinical supervisor, to also do all of your administrative tasks within your healthcare setting is near impossible. And this absolutely is a factor that drives out people to traditional settings to more lucrative, self-paid management sectors. And so that's a real issue for us. And then I just have a question. Probably Gina and Steve, you guys can, I had a really interesting board meeting at Hope Academy this morning regarding the potential to credential those that are less than 24 in the peer recovery space. And I think that's a real thing. I think that's a real issue to be able to certify 18-year-olds in the peer recovery space and have that be part of their graduation pathway in meeting this particular need that we still have in Indiana with high adolescent substance use. Is there a creative way that we could create that locally, or does that exist nationally already?
I mean, there's a lot of discussion about it nationally,
Okay.
and I agree and support it. And we've talked about creating a youth credential. There's some people that talk about doing it below 18, which I also support, but it raises liability issues and
Right.
concerns. But yeah, we should do that. I agree.
Because I definitely feel like that is a substantial pathway of getting these teens to higher levels of education to participate in the workforce for sure.
I feel like we have to be somewhat cautious because I could not agree with you more that Hope Academy is an example of an early workforce opportunity that we need to do a better job for. I mean, I'm just going to say it just like that. I do think that we should be cautious about how the system as it exists in emphasizing the need to credential. How does that weigh in with the students where they are in life and kind of the position that they're in? I think if there's an opportunity there for individuals who are interested in the field, an entry-level credential makes sense in every way. So why wouldn't we be talking about it with peer work as well? But I just, as we see so many changes moving so quickly around that early workforce space and how heavily we're emphasizing that stackable credential and graduating ready to go, I just think that in our world, we need to remember that we're talking about kids and students as we're discussing it, but 100%. Couldn't agree more. And Zoe, thank you for raising those points, because I think some of that context was embedded in some of the slides that I went through really quickly because I know we're kind of short on time. However, that need to align funding from the the services provided by PLA to allow us to support the capacity that they serve, I think is a huge connection that we can make. So yeah, thank you for raising that.
I think it's really interesting in healthcare how only physicians get paid to do an internship. Nurses do not, therapists do not. So that's time outside of your schooling that you have to go and work under clinical supervision, and there's no pay. There should be something to reimburse. That would be helpful. Secondly, this is maybe a little political, but I'm going to say it anyway. There has been talk of, that SEA won a few years ago, expanded mental health, and there's like people out there saying, build it and they will come when they talk about workforce, and that there's really not a problem. And I would just like to share that when I was working full-time, if you wanted to get into my practice to see me, it was 16 months before you could come in to see me as a new patient. For a psychologist in my area, it's over a year for somebody to get in for testing. So this is actually a workforce issue. We're not building it so they will come. We need to help these schools. I just wanted to put that on the record.
Absolutely.
And just to reiterate, it's not paying them for supervision, but Zoe mentioned the loan forgiveness. Just a little bit of history for people. We did pass legislation to get a loan forgiveness program. There wasn't funding for it, but people came together. The Attorney General's office had some extra money, Department of Health had extra money, DMHA had extra money, and they put it in a pot. And I want to say it was like not much, like 3 million, like a small number. And DMHA did an amazing job, created a board to oversee it, had a website, had the ability to review applications. Like it was awesome, I thought. And then we just let it go because it didn't get funded. And that's a mistake.
We also do, Department of Health it coordinates the state loan reimbursement program, the SLRP, right? So we do have behavioral health careers that are eligible for those reimbursements. However, the experience that you have in how much your direct contact is in the way that our pre-service is outlined, oftentimes renders folks ineligible. So that's part of the piece of the collaboration. We have puzzle pieces on the table that sometimes just need to be put together more effectively, and we can't continue just waiting for it to resolve itself.
So, you're just being mindful of,
Absolutely.
no, it's not about time, actually. It's being mindful of, the budget realities, right? So
Right.
loan forgiveness is expensive, obviously. It's not, I fully support it. I did hear from HRSA, they came down here, HRSA, that, we're just kind of not taking advantage of the existing loan reimbursement. So I'm wondering if, from a recommendation standpoint, if we sort of mention that directly, like we need to maximize those opportunities, and then we can go to the legislature and say, hey, we're maximizing every single opportunity available to us, and we still need something, as opposed to like, hey, give us more money for this, because we're already asking for money for other things. And now to be cognizant of time. So again, I would love to just adopt Gina's whole presentation and then add a couple things that I heard here. But which are, I love paid supervision, paid internships. I think those are two sides of the same coin, right? I think we should add that. OT as a treatment extender, I guess.
Could we also add NP as treatment extender?
Yeah. I mean, I think
NP.
that's kind of given, but yeah, I think that would be,
Okay.
I think that's,
We-
I think NP is sort of the classic treatment extender, right?
Well, nurse practitioners, allowing them to practice, to practice independently.
Well, that's going to come up.
Okay.
That conversation's going to come up. We're going to have it. I promise.
Okay.
It's just not right now.
Okay.
The loan forgiveness, like I mentioned, maximize all existing loan
Federal loan.
forgiveness.
Yes.
Yeah.
Agreed.
So take Gina's, add paid supervision internship, OT as treatment extender. I didn't know about this punitive thing. I don't like it. I'm definitely happy to put something like that in the report. I don't know if it's a specific recommendation, but I think,
Being more supportive.
yeah, I
to
fully
that
agree.
workforce
That's
process.
terrible. Like that's happening.
And the fact that it lives as an administrative procedure
Yeah.
is probably the part that's
Yeah.
the stickiest.
I just don't
for
know
me. Yeah,
legislatively
like-
how you do that, but I think we can definitely mention it.
Mhm,
Or-
mhm.
I don't know if it's appropriate to have administrative coordination between DMHA and IPLA Behavioral Health Board, but I think that's needed and should happen, and sometimes they're going in different directions, and those of us in the field are aware of it, but not always sure that the two bodies are. So you could put, maybe, I'm throwing that out, the coordination, collaboration between DMHA and the Behavioral Health Board.
I'm down for that.
Yeah, all right. All right,
Yeah.
that'd be Gina, all right.
Yeah, just as on this paid supervision piece, this is just worth stating, there are still folks that are charging students for their
So the students
supervision.
have to pay.
Yeah, so I think if we can build that in as an absolutely not and figure out, that would be helpful because people walk. They don't have, graduates don't
Nobody
have
should have to
funding to
pay
do
for
that.
their own
No,
internship.
they should not. Yeah, and that isn't happening as much as it has been, but it is still happening. Yeah.
And
The playbook recommended, thinking about a state income tax credit for that solution. I don't know how specific we want to get, but.
Obviously.
Call out, I guess, yeah. that's-
Yeah. I know that funding goes as long as possible. So we were trying to elevate as many strategies as we could that did not have a fiscal ask for the reasons that everybody knows. But I'm clearly would be supportive of, not that it matters.
We can,
I support, but
why don't we
just
just
to share
mention,
it.
why don't, we can write down to mention that as more in the body as opposed to like a specific recommendation,
An example.
and
Yeah.
an example.
And I don't know if you wanted to say this or not, but to me, there's also a difference between funding for various things. And as we said, reimbursement to encourage evidence-based practice. And to me, that encompasses all that we do, as opposed to funding for specific things that we may or
Love
may
that.
not include or miss.
Yeah, and we got some of that in CCBHC. We'll talk about MSD later, so I think that.
I need to ask a question. I supervise psychiatric nurse practitioners. I do that. I don't want to charge for that service. I work for myself. So if we did something like this, would that require me to to have to pay myself or, you see what I'm saying, to pay more? It doesn't
I think we
make-
could probably start at the CMHCs or something like sort of as opposed to,
Okay.
because I think that
I
what.
won't be opposed.
Yeah, I'll be all right. I mean, because I think that the truth is CMHCs are sort of a training ground for a lot of our workforce anyway. And I think that, we can see how that goes and then.
Build
So,
from
does
there.
that work? Does
Yeah.
that way we leave flexibility for kind of independent practitioners to do that. So. All right, can we turn all that into a motion? All of Gina's stuff and everything we talked about.
I, yeah.
All right,
Second.
all in favor?
Aye.
All opposed. All right, cool. All right,
Thanks,
thank you so
everyone.
much, Gina.
Thank you, John.
Appreciate it. All right, let's move right along because we have several commission members. So I will at some point channel Kelly Hartman, who's our IDD expert and honorary commission member, and talk about a couple IDD things, but we'll do that later. I want to start with Dr. Yoder. If that, you ready to
Yes.
go? All
And I
right.
think I had 8, but I think we talked about.
talked about a lot
10
of
them.
Okay,
So I
yeah,
just
great.
picked 2, and maybe I'll,
Fantastic.
since MST came up, maybe we should just
Beautiful.
go into
Go.
that. We're all familiar, but it is for this group of adolescents who are most at risk for these very much more expensive placements, out-of-home placements, residential, jail, some form of DCS situation. And it's a therapy specifically designed for them. It's more intensive than wraparound because the therapists have, instead of, maybe a caseload of 30, they have a caseload of about 5. So they are meeting with only 5 families multiple times a week. And the crucial difference is they are on call 24/7. So it's almost an enhanced crisis response system because their families can call someone they know who is able to say, remember the plan we have, remember the next steps, let's utilize these things. And they have amazing outcomes because they are safe, because they're preventing this very expensive treatment that it's on placements for that we don't want to separate families for. You save $3 for every $1 spent is kind of a well-established thing with other programs. I think another difference is that it's among these evidence-based treatments, it's well-established. And then not only do agencies who start have to go through a fair amount of training process, it's ongoing check-ins where once a week they have to meet with an MST expert to make sure they're adhering to the evidence-based practices. So DMHA has appropriately supported this and is doing a 2-year support for agencies to start this off. Right now, 14 counties have this available. But the problem is, of course, billing and funding reimbursement. The traditional billing codes don't cover this level of intensity for one therapist to work with by families that's kind of needed, despite it saving costs exponentially over well because they are able to keep kids in their homes where it is working right now because those kids who are already involved in DCS and juvenile justice systems are able to use the Family Preservation Services per diem 113 that pays for it. So in 13 of the 14 counties that have it, it is only available to kids who are already involved in DCS or juvenile justice, that's a population it needs to serve, but would love to serve kids before they are involved in those systems. And then the one county that has it is able to use the startup funds, but those will expire in 2025. So the people who are in charge of MSD would like us to consider 11 other states, including Kentucky and Ohio, have adopted just a higher MST specific reimbursement rate. Like you can bill for an MST services that is at a appropriately higher level than your just traditional therapy billing rate. But other things that we could maybe consider is how it's leaking in with CCBHC and crisis mobile response. I just think that the MST people would feel more secure about that higher billing rate code.
Can it be reimbursed through CCBHC?
So mechanically, I think you could say MST is an evidence-based practice that we want to do.
Yeah.
And we'll build it into our PPS rate. Now, what that will do is it'll jack up the PPS rate. So it's not a mechanical problem, it's a fiscal.
Gotcha.
But that's good. That's a good question. Any discussion? I mean, I think, again, I think that we would lean on the MST Center folks, Dr. Rodriguez, to help us make this case, if we incorporate it, but, discussion, comments, questions?
I mean, we probably all agree with the question being the fiscal funding question.
Sure, I think we just have to, we have to recommend some things that will, we'll see what happens, right? Our job is to recommend things and.
And I think it has a clear way to say the cost savings for every.
And we'll need that point made really,
Others,
really, pointedly by the MST Center folks. Any motion to approve this one?
So moved.
Okay.
All in favor?
Aye.
Opposed? All right.
All right. and
Second one.
The other one is what we've talked about, the provider psychiatry consultation program. So we have 2 of those now in the state for kids, the Be Happy Behavioral Health Access Program for youth. And now in the last year with DMH, we support CHAMP, which is to always check consultations for healthcare providers in addiction, mental health, and perinatal psychiatry, but to not be confused with CHAMP. So,
Whatever.
yeah, I mean, we heard from IDD, we heard in all areas needing we know that people access their mental health care from their primary care providers, super appropriate for mild, low, moderate intensity. And I think even those with severe mental illness, some really prefer to access it with their primary care providers because that's where they feel comfortable. That's where it's easy. They don't want to meet with a psychiatrist. They want to meet with another person. Primary care providers already cover about 40% of all mental health appointments. Pediatric primary care providers cover one third of pediatric visits are mental health. But their training is lower that in this area, they feel uncomfortable, especially for the quantity and severity. And so this is a program that supports them. They can call, say, hey, this is what's going on. I started this thing, but that's not working. I don't know what my next step is, or now you told me to screen. So now I'm screening and now I found this problem. What do I do next? Whereas before there's some, well, I don't know what I'm going to do. Why am I asking about this question? So both programs and CHAMP, in particular has huge growth in the last year. Be Happy over the past 5 years now has served people in kids in 87 of our 92 counties. People are routinely using it in their practice. And then we hear from them that good provider feedback, and they've even, a recent one said, I've taught my colleague about this, or my colleague had this question, so I shared this in my clinic. It is one of 46 states have a child program like this, and currently the child program is supplied by federal HRSA funding from the American Rescue Plan Act through September 2026. We have not heard from HRSA any guarantee that we will have another opportunity to have a more extended grant. And then CHAMP is funded through DMHA through 2025. So this is kind of the legislative session for these programs. Some programs who have had sustainable funding in other states do just have a state budget item, but others have started to use this pooled insurance funding mechanism, saying that every insurance company that operates in the state proportionally funds these programs. So if insurance company X serves 15% of the state, it will fund 15% of this program, which so these budgets for these programs range from about 4 million annually to like the really high, like Virginia is doing a 14 million annually, which we're doing pretty well with our like 3 million annually and getting a lot closer to what Virginia is doing. But so when you think about 15% of that for an insurance company, it's really relatively cheap, maybe a couple $100,000. And I think insurance companies understand that right now, like our federal government is paying for expert consultation for people who have insurance. We just don't have a billing mechanism to make that happen. And insurance companies, generally they pay for expert consultation in any other setting. It's just hard to do this from a telephone standpoint. So I think we would recommend support, and from a funding mechanism, maybe this insured or insurance pool is funding. Other states also use that mechanism to fund their vaccines for the state.
So I know in my area, we have psychiatrists who are doing this with primary care providers. Do we already have something in place for adults? Because
That's the CHAMP.
it is, okay, there.
The Be Happy's kids, CHAMP is adults perinatal. So yeah, I think, that we can just completely steal a statute from Washington. I think Washington State's the first, well, a couple of states are doing it now. Where it'd be great to get a non-super blue state. I don't know if we can, but we'll take a look.
Louisiana's working on it.
Louisiana, well,
Missouri's working on it, like
that
a
would be
lot of
amazing.
our
Yeah, all
peers
right.
are working on it.
Yeah. So I guess the recommendation would be to continue to sustain access lines through the pooled insurance funding mechanism. Any discussion, objection, questions?
Do we need to open it up for other mechanisms?
Or I guess, or appropriation, I guess. I always want to leave that out, right? What do you think?
Throw whatever you want.
Yeah, all right. And or appropriation, yeah, we'll do both. We'll just in line with the other funding recommendations. Get a motion?
Motion.
Second.
All in favor?
Aye.
All opposed? All right, you're good?
Well, I guess one other that went along with the workforce was funding for residency positions.
Oh, yeah, it's important.
I think
We can just say that.
Oh, what?
Just
We'll
say
just say that.
yeah, funding for residency positions. Again, we'll put dollar amounts to it, but I think later, but. Any motion there?
Motion.
Second. All in favor?
Aye.
All right. Cool. You good?
Yes, that was.
All right, thank you so much. Zoe, you ready or? Oh, sorry, caught you plugging your laptop in. Let me do Kelly's real quick because they're real short. So she mentioned that this is a really, really narrow thing, which I think we need some narrow things because we're asking for big things. So change the title of a BA level RAP facilitator to something other than behavioral consultant because it gets it gets confusing. That doesn't need to be a statutory change necessarily, but just something to recommend in practice. Does everybody remember that conversation where there's behavioral consultants in mental health and behavioral consultants in the DD world that do completely different things, and people get really confused by it. Real small thing.
Second.
All in favor?
Aye.
All opposed? All right, that one passes. The other one, which I think is really important and is so in statute, I think it's really important to put this in statute. A clinical liaison between DMHA and DDRS actually in statute. And the reason I think this is important is because the example I use is the suicide prevention position, right? Which was put into statute, 6-7 years ago, something like that. Like, so the statute literally says the director and the suicide prevention position are the only mandatory position at DMHA. If we add this to it, I think it would give sort of a veneer of legitimacy to like the idea that these two entities have to work together regardless of who the various directors or secretaries are. So anybody opposed to it? Give me a motion to add a clinical liaison position to statute.
I motion.
Second. Any second? All right. All in favor?
Aye.
All right, cool. The other one was the health homes waiver thing, but you're gonna talk about that too.
We already talked about that, doing the health on waivers, right?
No, we haven't. Do you want to talk about that? That's it. That's part of yours. Because Kelly mentioned it too.
Yeah, Kelly, yeah, I think it was shared during the IDG session.
Yeah.
That currently it's either an SMI waiver or an IDD waiver. There is opportunity federally to do a waiver that would include both of those, and that would really prevent people from, you know, in our worlds now currently, it's this issue, it's your problem, right? Because of those separate waivers, this would help in having a payer source to be able to not have this, but to have more of a joint effort. So a joint waiver.
Yeah, so the recommendation I think would be sort of, and this is where we have to be mindful that it's probably not happening next session, but we should put it out there, right? So consider a waiver for dual diagnosis.
Yes.
Braided payments, essentially. And we'll flush that out.
I mean, I venture to say this might be something we could do this session because it eliminates some of the other things that.
It does.
Yeah.
Absolutely. Oh, yeah, I mean, that's your business. Not mine.
Motion.
Second.
All in favor?
Aye.
David and I will work together.
All opposed? Okay. All right, that's all for Kelly, and that was one of yours too. So do you want to keep on with the other ones?
So, is it the ones that you emailed
Yeah.
me, sir? Okay, so I just wanted to make sure I was reviewing the right one. So we did the IDD one. And then the other recommendation, and this was, I sit on the youth justice work group. And so they are doing a lot of work to help with keeping juveniles, you know, out of the detention center. So these recommendations came from that work group. Review system standard requirements as far as with DCS, Medicaid, DMHA, for staff qualifications to provide services, and B, requirements for reports to remove unnecessary barriers to inefficiencies in service provision. So there's a lot of places where this falls through the cracks. And so if we can review those and standardize that more, then our juveniles are at less of risk. So that was one proposal from that.
So you're
work
saying
group.
like a line, make sure that, you know, there's not different requirements for the different, depending on the funding source.
Correct.
For service.
Yes. Mm-hmm.
It's a non-monetary things.
Non-monetary.
We want those.
Yes, we want some of those too.
Any discussion on that one?
I'll move that one. That was part of the discussion we had to judge.
All right. Second. All in favor?
Aye.
And then you already addressed the one as far as the established no reject, no eject. So we talked through that already. And then infuse system with parent education regarding, and I don't think we've highlighted prevention enough yet in this, and parent education is part of that regarding developmental stages of children. Learn the science, you know, free materials. There's lots of materials that are out there, but having a sustainable source, a sustainable program for both prevention and parent education was another recommendation.
think that kind of ties into almost like a marketing campaign. There's like a You Matter out there for teens and things. Almost if we could get something into the schools where, we start to move towards that prevention effort. To let these children know they're not alone and to avoid using drugs, very important.
Yeah, we can highlight some of the stuff we're already doing and maybe emphasize the need to.
My friend Steve Beaver would say
Yeah.
it starts at birth.
Starts at birth,
Start
right?
at birth, right? But that prevention component, I think we could
I
elevate.
think
a little
parent,
bit.
family education.
Yeah.
Because this is the recurring point and recurring theme, which we'll highlight is this is the whole family,
Right.
not just a kid or parent. Any comments on that one? Motion,
A motion.
all in favor?
Aye.
Opposed?
And then do you want me to address the SMI group home situation?
Sure.
Okay. So, and then the other one, that I've talked with several of you on, so CCBHC, the 9 core services that are on there, it does not encompass group home. And so some of you might know, but some of you might not know, we, have significant, group homes in our state. However, the only funding source for that patient population mix and for that model is the services that are done within that group home. There is no operational per diem. There is no overhead cost. And so the sustainability of our group homes, we have lost significant beds and therefore the wait list at the state hospital is significant. And so proposing a per diem for our group homes for our SMI population still needs to be in addition to of CCBHC.
And it's not super expensive. I mean,
It's
what's the
not
number you guys?
compared to, state hospital, right, which is about $2,000 roughly a day. We're a couple $100 a day to maintain group homes. And it's a jail issue, a hospital issue. It's across the board without these beds and they're aging. So without that funding, we're not able to keep up with the aging population and the needs that we're seeing that are very extensive.
Questions?
I do have a question. When you say aging, at what point does long-term care become involved with the placement of those individuals?
Yeah, that's very challenging. There's some federal issues there as far as how code reads that we're working on a federal level. Some just outright refuse because of having psych. But yes, a long-term mental health. Long-term, that is a great vision to have. We need to have a long-term as a next step.
It's a good question because I think that it's, and I think we should mention it when we talk about.
We
it.
have, yeah.
Any other questions for Zoe? Motion.
Thanks.
All right. Motion second. All in favor?
Aye.
All opposed? All right. All right. You're good, I think.
Yeah, I think that's my best.
All right.
Did I cover all 4?
You did that. Well, yeah, you did. That was
Okay.
well done. All right, let's jump real quick to Representative Wilburn, who did not submit one beforehand. So, but I'm letting her come in.
Thank you.
Generous chair.
Yes, I appreciate you,
Sorry.
Chair. I appreciate you. Throughout our day, we've talked several times about communities that intersect our communities in crisis, and that's first responders. Based on the good work that myself and Senator Kreider did my first session, I would like to see sustainable funding for mental health and resiliency training. We've now become a leader in the country of what mental health and wellness looks like in public safety. And so in that regard, that needs to be included in sustainable funding.
For first responder resiliency.
Yes.
Any comment, discussion? Motion.
So moved.
A second.
All in favor?
Aye.
All opposed? All right, and before we turn to Jason, I want to make sure there's nobody else, because I see we covered yours. Jason's gonna bring us home. Anybody else?
Just want to
Oh, yeah.
ask, that mental health resiliency training, is that really similar to trauma-informed care?
Well, it's not,
There's a specific program actually that she's referencing, but yeah.
it's not exactly the same. obviously am a proponent for trauma-informed care and to try to push it with various population. We've done some law enforcement training, but really it's based on their interaction with the people they're interviewing after a sex crime or something like that. And so it's been a really positive feedback. But, you know, I think, Representative Wilburn knows, I like to think at some point we'll get to the point where public safety folks have a annual mental health intervention, just like they have a physical. Just based on my personal experience and the things I've seen with other individuals. And so the trauma-informed care will continue to push and advocate and things, but this course is very specific to public safety.
So distinctions between trauma-informed care is more about interactions with the general public versus what we're talking about here is for first responders to help them deal with the trauma they're seeing.
So it's more of the
Or
personal.
their vicarious trauma symptoms.
PTSD,
Yeah.
accumulated PTSD.
And how their vicarious trauma impacts their personal lives. And so this specific training is actually done remotely. And we're seeing great success in utilization because the stigma to go into say, I need help was one of the barriers. And so now they can do this remotely, which has been wonderful.
Well, there are several nurses that, I mean, I've even treated some that had PTSD
Yes.
related to COVID.
Yeah.
And they can be considered first responders.
Yeah.
Am I correct?
Yes, I think, and actually Representative Ledbetter, that was another population that came forward after this bill passed and said, we actually need this for ourselves as well. So maybe another recommendation is expansion of education and training for discipline-specific mental health and well-being.
Make it a motion.
Motion.
All right, second. All in favor?
Aye.
Opposed? Did you all get that? Great. All right, anybody else before we turn it over to Jason?
Can I just make one comment
right.
about the insurance? I'm sorry. So going back to the parity, we just want to make sure that we ensure that the insurance company doesn't trade out of pocket for higher premiums for employers and that gets passed to consumers. Because that is what would be done. And so that is from one of my members that I wanted to
Yeah.
make sure to
I
pay.
think we can
for.
make sure to incorporate that in comments
Mhm.
of parity.
Yeah.
All right, Jason, it's your show.
Now, Mr. Chair, would you prefer I go with what we would consider the lower level ones or less?
The less controversial.
Less controversial.
Yeah, go ahead and start with
quote,
those.
No, a couple of them have already kind of been, we touched on, so they may be just more of a mention, not necessarily a recommendation. I'll kind of leave it up to you and the rest of the commission. One is with regards to the standardized data collection, especially around older adults across kind of behavioral health and really all health systems. And this would probably require creating position because I think there is data out there with regards to Medicaid population, long-term care population, but we're also talking about there are large swaths of adults that are not in either of those camps. So I think it would just a recommendation to ensure that there's data collection for state agencies for older adults across the spectrum, because as we need the data and anything we can get, especially if it comes to time for funding, reporting out, et cetera, got to be able to show those numbers. And I think having that for older adults would be something we would like to see recommended in the report.
Any discussion on that? Motion.
So moved.
All in favor?
Aye.
All opposed?
All right, cool. The other one is kind of, we've talked a lot about we've been talking about the mobile crisis units, and I just want to kind of call out something regarding mobile integrated health that the General Assembly did last year, specifically around the Community Cares Initiative grant pilot program. It was in HGA 1385. I think the standalone bill was Senate Bill 10. And just wanted to kind of reemphasize that is there in place, and if we can encourage support and funding and I guess expansion of that program so that more public safety entities and communities can use that as an opportunity to do that, to be that connector to the services that are out there in the community.
Yeah, we're going to put out our RFF shortly. Can't give
Okay.
time on it on
Okay.
that. I'm up to you if you want that to be a formal recommendation.
I'm open to have that as a formal recommendation. I'll leave it to the rest of the.
So continue to support and evaluate mobile integrated health.
Yeah, with the caveat that it is integrated and worked with the 988 and crisis, because the last thing I want is to create confusion and silos in the communities that we serve, especially within the SMI population. And so I think the more we have out there, that creates that confusion, right? And so if we can integrate and support and collaborate together to work on that in the local communities, I would be in support of it. There's some communities that's gotten really messy and people have fallen through the cracks as a result.
Yeah, I think our as well. Why don't we table this?
Okay.
As a recommendation, just because I think let's see how this plays out. I think it'll play out the right way, but I think it has the potential to get messy. Or
The other thing is, with regards to, is this more of having encouraging more health systems in the state of Indiana become age friendly. So what this is this is an initiative from the John A. Hartford Foundation Institute for Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the United States. This is, as you all may know, AARP has their long-term services and support scorecard. Traditionally, Indiana has performed very poorly in it. The most recent edition of it that came out last year, Indiana did make some gains. One of the most significant gains, in fact, we were number one in the country in this regard, is the establishment of age-friendly health systems. So what does that mean? That means it's just making a commitment to focus in on what they call the 4 M's, which is what matters: medication, mentation, and mobility. I think mentation is probably what it would be the focus of for our purposes. But I think there's some good momentum around this, and it's just more encouraging more health systems to adopt this kind of viewpoint in regards to being more age friendly, because our population is getting older.
and there's metrics and measurements that already exist.
Yeah, so this is also part of the, like I said, it's part of AARP's LTSS scorecard, and that is where Indiana has actually performed the best. So it's kind of continuing that momentum to see if we can grow it further.
Jason, could we take that one step forward to say not only health systems? I think of mental health as health, but some do not. And since it's the Behavioral Health Commission,
Yeah,
could we say health and mental health systems to
Yeah.
be age friendly?
I think some of the folks that are practicing right now are also in the long-term care space and things like that. So they're already kind of dealing with some of those issues, but I would agree that would make the most sense to include that.
And other discussion, that's a good point. So we'll make it clear that we mean health and mental health.
Mhm.
In favor?
Aye.
Opposed?
All right, let's end with a
All
banger,
right,
as they
let's do
say.
this. All right, let's go.
So the policy that the last, my recommendation is removing the collaborative practice agreements that are required for advanced practice registered nurses. We've been talking about workforce throughout the entirety of this. This is a workforce that is being prevented from practicing to the fullest extent of their license in some cases. And what we have seen in other states which is more than half the states in the nation, have removed these practice agreements. What we have seen is that in places that have done that, they have seen their APR ranks grow. And they've also seen, I think, especially in Arizona, they saw that 70% of their APRNs were locating to rural areas. There is a tendency, and obviously Representative Ledbetter is way more qualified to talk about this than I, as she has carried this legislation. I believe Representative Wilburn, you were also on that legislation last year. What you have seen is that there's that clustering with regards to providers because they need to find that practice agreement or somebody who's willing to collaborate with them. That is also a burden for a lot of APRNs because they may not want to practice, or they may have trouble finding somebody with which to get that practice agreement in place with. It also leaves them to the whims of whoever they are in an agreement with, that if they decide to just up and just, hey, I'm done, I'm retiring, I'm no longer going to be able to collaborate, then that leaves them scrambling, trying to find somebody. And ultimately what this comes down to is what something Representative Ledbetter and I think we're all focusing on is patience and Hoosiers that need access. And this is a way to help increase that access, especially in our rural areas. And I think it is something that we should remove this administrative burden to allow our APRNs to practice to the full extent of their training and their skills. And I think that it also has a unique role that it can play, especially for this discussion. I know that we're talking, this has the potential for larger healthcare beyond just this space, but I think that the topics that we've been discussing, it's uniquely kind of positioned to help with. At the first meeting in January, we had an APRN who spoke to us who'd been practicing in this area, specifically around, in the psychiatric space for 40 plus years. Our physicians are overburdened in a lot of ways, and a lot of this is a way to maybe help relieve some of that, because we're just beginning to get more providers that are able to practice and give folks the access that they need. So I'll happy to yield to Representative Ledbetter or anybody else who more.
I just want to state that the collaborative agreement requires that a physician sign off on 5% of my work, 5%. That is a very, very small requirement. It's not direct supervision, it's collaboration. Working within our scope, we do collaborate. If we need to speak with somebody else about something, we do that as well. There was one other issue I wanted to bring up, but I don't, kind of lost my train of thought again. I'm really good about doing that.
So Jason, would you make it the recommendation specific to psychiatric NPs or just NPs?
Well, my recommendation would just not have that restriction, or just because I think it should be beyond that. I understand the report that is being what this commission is focused in on, but I think it should be beyond just the scope of what we're saying in regards to behavioral health. I think it's uniquely aligned with this and why I wanted to make it a recommendation. But I think it can't necessarily be.
Our focus, we haven't touched on maternal mental health at all, but I see this as a solution to maternal mental health and maternal provision as well in the perinatal space. And so I think we should leave the recommendations open-ended.
I would also like to state, I have primary care providers who are physicians who refer patients to my practice because I specialize in just one thing. But I will tell you that there will be pushback from nurses, the American Association of Nurse Practitioners, if it were just for psychiatric providers.
Right.
There'd be a lot of pushback on them.
I have a question, a clarifying question. During the height of COVID, weren't collaborative agreements suspended during the requirement for that suspended during that time?
They were suspended.
And so did we have negative effects during
No,
that time?
we did not.
So then I think that we already have data to support the fact that it's not needed, that the collaborative agreements are necessary to ensure that healthcare is provided at a high standard.
And it basically comes down to ISMA, and I've asked what that fear was, and I was told the fear was that they're afraid if they allow nurse practitioners to practice independently, that physicians will get pushed out of the hospitals, which is not possible because physicians are educated differently and they will always be needed.
So let me weigh in here. So I'm just, spoiler alert, I'm going to abstain from this because in my view, especially wearing my DMHA hat right now, these are sort of competing trade-offs between two entirely good faith positions, right? I think that there's a genuine, I think, push from the Jason and everybody that to increase access. And that's really the name of the game. I think that there is a genuine good faith, patient-centered objections from some physicians, and physician groups about the kind of quality in education. And so, again, but I also know this is important and we need to deliberate on this, which is why, I'm good with having this conversation. If you want to say something, Dr. Yoder, you can, or you don't have to. I mean, I think, yeah. So, yeah.
All hands on deck for mental health workforce.
Yeah.
And I don't think we should act out of fear, but what will come at us is that has some legitimacy is that APRNs work in all fields of medicine. We heard from primary care, which seems very legitimate for us to talk about. We heard from psychiatry, which seems very legitimate for us to talk about. It feels like if we were making an all medicine recommendation, we would have more of a leg to stand on, and maybe we could, I don't know if we want to consider that, but to talk to hospital associations, APRNs work in surgical ICUs and dermatology offices and things that, yes, all mental health is health, but some that consider themselves completely out of the scope. And I guess I worry that we would become called out on not having the standing to make this broader recommendation.
And that's, I mean, like, that's a very fair point. I think, look, I mean, what we put in the report will not dictate what happens next legislative session about this. Like, to be clear, like, I think like this is one thing, it's one sort of data point that will go into a much more robust discussion with a lot of lobbying efforts spent on this conversation. But I think that that's a really, really fair point. And perhaps there's a way we can incorporate that into our discussion.
Do we have another, that is our scope, do we have another meeting?
Well, we had a point that 40% of mental health is provided by primary care providers, and family nurse practitioners are primary care providers.
Absolutely.
So that
Could we do it?
That does.
Psychiatry and primary care about recommendation, or, I mean, I hear the concern that what about the nurse practitioner?
And Jay, I don't think you're giving yourself enough credit, or the commission enough credit. The Behavioral Health Commission's was the igniter that created Senate Bill 1, and mental health was actually a priority
Sure. No, yeah.
for the first time. So I think this is a platform that really is a catalyst.
I'm aware of how great we are.
Right?
I think, I think like to Dr. Yoder's point, this is bigger than mental health. This will be sort of like all health professions kind of conversation. So anyway, I don't know how Jason,
I have the opinion much along the line of what Representative Ledbetter here is that this is, as she just mentioned, with 40% coming through primary care, I think just restricting it to primary care or psychiatric, or while that may, I guess, quote unquote, make it less controversial, I don't think that is what we need. I think there needs to be a broader discussion about this. And I think that this is maybe one of the avenues by which we can have it. So I would recommend that we would keep it to just removing that collaborative agreement for APRNs. And then we have it out from there, I guess.
The APRNs that work in dermatology and that work in these specific fields, they're trained in family nurse practitioner. They're trained as primary care providers. And then they choose to subset into that field. There's not there's only, I think, primary care. There's a family nurse practitioner, which is a primary care provider. There's psych. I don't know that we have a midwife program in Indiana. I don't know that we have forensic nurse in Indiana. I don't really know that there's another field in Indiana that you can go into beyond that. Just to clarify.
Sure.
I think I want to give another context of healthcare providers. So physicians, when physical therapy went after independent practice for up to 45 days, it was very controversial. Physicians had expressed desire that if somebody has an orthopedic injury, this will prohibit treatment, XYZ. There was a lot of concern. And with time, this ended up passing, and physical and occupational therapy both have direct access to patients for up to 45 days without a physician's referral. And we have not seen any of those indicators in regards to a decrease in patients seeing physicians in lieu of. I think the concern is that nursing is a different scope of practice. It's not medicine. So that's kind of where my head lays and where I wrap around. I do think that this could be included in our commission report as we talk about workforce expansion. That would be an appropriate insertion.
The right place.
And then to allow it to sit there and simmer and let these other conversations that we know will inherently pop up.
as far as where I think it would fit, it would fit under workforce, right?
Yes.
That's the idea. And I think that, you know, what I want to do now is have a motion and then a roll call vote. So anybody can kind of vote, you can abstain too. It's fine. And I do, if this ends up not being, you know, unanimous, I want to note that in the report as well too, because I think it's only appropriate and fair to give people the opportunity to say this was not part of it.
Yep.
But we only have a few minutes left. So, I guess.
So my fear is a little bit like the politics base.
Yeah,
I don't know how much like
Politics.
we need the Indiana, it feels like we need like the Indiana American Academy of Pediatrics to be
Yeah.
fully behind the commission. We need all of the academies of all of the physician groups to be fully
Yeah.
behind. And I guess I don't know how they would respond to this. It feels negatively, but maybe, and then I also don't know how much we need their support.
Sure.
I
Those are all
know
great
it's necessary.
points. And I think part of this will be kind of where if it nests under a workforce recommendation, which again can be, the nice thing about most of these is they're pretty discreet, right? Like there's not going to be a bill filed by somebody that's just behavioral health commission recommendations one by one by one by one. These are parts they're going to be, I mean, the 98 CCPHC stuff will be done mainly in the budget discussion, right? And so, but I think you're on the record, you're heard, understood, watching the bear. So, you know, that's what they say. So, and you know, if and when this ends up torpedoing it, you can say I was right. But we don't know. And let's have a motion, do a roll call vote. So what's the language of the motion, Jason?
So I would just move that the commission recommend the removing of the collaborative practice agreement that limits advanced practice registered nurses from practicing to the full extent of their licensing.
Second. All right, let's do a roll call. So if we can note for the record, roll calls. Representative Ledbetter,
Yes.
Jason,
Yes.
Michelle, David,
Yes.
Piotr, Steve.
I'm a yes, and just to explain my vote, I think this as a concept, so I don't know if this is helpful in terms of the report, but this should relate to any scope of practice of any profession that enhances the workforce for behavioral health. So it includes nurses, but to me, it shouldn't be limited to nurses. So I vote yes.
Senator Hubbard,
Yes. Yes.
abstain.
Yes.
Yes.
All right,
Thank you.
motion carries. And that's you're good.
I think that's it for me. Yeah.
All right, thank you. Yeah, good job, Biz. Thank you. And you know, you're gonna be writing a lot of this, so.
Fine.
All right, so in the 5 minutes we have next steps, our team, along with several of you, will be kind of putting together a drafty final version of our report. And sending it out. We will send out, I don't know, I owe you a poll or a date. So we'll send out a doodle poll as well for our next meeting. We're looking sort of mid-late August for that. At that point, we hope to have a kind of discussion vote on the final report. If we need to have a meeting in September, we can. We have to October 1st to finalize a report, but we're hoping to get it done then. So if you get an email from me asking for help drafting, please say yes. We're going to do our best to again, keep it short, keep it targeted, but also make sure we accurately capture the wishes of the commission. So any other comments before we close out?
Question, we're not gonna have, I'm assuming we're gonna have narrative recommendations, not bill drafts, or even an appendix with bill drafts.
Well, if we think we can easily get to bill drafts and you want to volunteer to lead that, Steve, we can, we can talk about it.
I mean, I'm willing to do whatever you want. I think.
What do you think we should do? I guess.
The parity one, I will be drafting with those of you that are interested. And if we wanted to make it part of the report, we could just throw that out.
Yeah, absolutely. Yeah. And I think that's one where I think an actual language will help. Because the language actually does explain what it is. Whereas like the funding stuff is going to go into the budget discussion. So I think it's sort of a case by case scenario. I mean,
The APRN app.
yeah.
Another-
I think for the the access lines, I think language actually makes sense.
Another question around those lines is last time we took that commission report and then Steve, myself and Nomini pulled together an advocacy toolkit and we got everybody under the same tent. Are you wanting that as a next step of that commission for us to work on that?
Why don't we talk
advocacy
about
gap?
that at the next meeting?
Okay.
And I think, we're small enough where I think everybody's gonna be on the advocacy subcommittee. I mean, we had 24 people last time.
Okay.
So, but yeah, I think that's ultimately, end of the day, I mean, that's really what matters is.
Okay.
is who-
Discuss what we need to carve out. Is that what, from the primary legislation, is that?
Carve out.
Well, like, if you do the mental health parity as part of the report, what do we wanna discuss, what we leave out and what we?
Yeah. So I think those conversations will happen between, kind of some smaller pockets of commission members, probably me, you and Steve, and then we'll kind of get to whatever draft we get to. So again, I think we've achieved our goal, which is we have our marching orders about what, roughly speaking, this report contains. There's still a lot of work to be done in terms of fleshing it out and putting details and numbers to some of these recommendations.
One of the things I'd like for you to think about is I personally find this very valuable, this experience, and I'd like for the commission to continue. I know it's work for DMHA, but Jay mentioned that when he talked about the path that we're on, and this isn't going to happen in 2 years or 4 years, right? And so for me, one of the recommendations I'd like to see is that we continue the commission.
All right, quick motion.
I
Move that.
I second.
All in favor?
Aye.
Director, before we adjourn,
Yeah.
you gave us an analogy regarding Star Wars. So where are we on the journey?
I mean, I think we're sort of wrapping up principal filming on Empire Strikes Back. But we still have to do the kind of final cut.
Fair.
All right, that makes sense.
Great job.
All right, thank you. All right, we are adjourned.
Thank you.
Thank you. No, I'm good. This one was easier.
It really is.
It's just harder when you know.
I don't think so.
I'm just channeling.
Have a great night.
You too.
Thank you. I think that actually, it'll be there. Yeah. I mean, it's kind So they're, they put together.